Event, and we're thrilled to welcome Professor Serena Hugh from Stanford, and we'll be more formally introducing her in a few minutes. And we just have a few introductory slides, and Albert and I will kind of walk through those slides together. We're pretty good at tag teaming these events. We have many people to thank and to acknowledge, and we'll kind of do that through the course of these slides. And then after our introductions, then we will have a number of greetings from the University of Toronto Department of Surgery and the divisions of neurosurgery and orthopedic surgery. Cool. So, wasn't quite sure how those slides were done. So, it's become, I think, a traditional and I think kind of an important aspect of what we do to have a land acknowledgement, a statement, and this is actually a beautiful piece of art by an Indigenous artist, Simone McLeod, and it's entitled "Healing Together." I thought that was kind of appropriate because I think that our Indigenous ancestors would feel that what we're doing here today in the setting of a university and in the hospital, in the spirit of trying to help people with serious spine issues, I think would be quite welcomed. So I just want to wish to acknowledge this land on which the University of Toronto and the teaching hospitals operate. For thousands of years, it's been the traditional land of the Huron, Wendat, the Seneca, the Mississaugas of the Credit. And today, this meeting place is still home to many Indigenous people from across Turtle Island, and we're very grateful to have the opportunity to work on this land. We've been on I think, quite a remarkable journey in terms of bringing together a fantastic multidisciplinary team at the university, the various teaching hospitals in the divisions of neurosurgery and orthopedic surgery, but also a whole host of non-operative specialist programs, as well as researchers from various disciplines. And I think this really embodies the spirit of integration, collaboration, research, and healthcare delivery. So Albert and I have had the privilege of co-leading the spine program for the last number of years, and we're very grateful for Nadia Jabber, who is our program manager and who's been quite instrumental in putting to date together. And big thanks to Carol Swallow, our chair of surgery, who'll bring remarks, and also our two division chairs, Galerie Jade and Peter Ferguson. And then we've got a fantastic faculty, and I won't list all of their names, and many, if not most, are here today. And these really represent all the various teaching hospitals in the University of Toronto Spine Program, as well as the University of Toronto. And we also make an effort to reach out to the community beyond the University of Toronto Tassin hospitals. So we've kind of got this cone here to kind of give you a bit of a sense of the different areas that the University of Toronto Spine Program has been active. And the program itself was conceived in 2009 after an external review, and we've got a timeline, a diagram that we'll just walk through in a moment, just give you a sense of the development. The reality, though, is that while the program itself was conceived in 2009, it actually built on a very strong background of excellence with many leaders in the field, and two of whom are here, Drs. Tatter and Hall. but a number of individuals. And so we've kind of have built from that to develop, I think, quite a strong program that includes collaboration, fellowship training, education, research, as well as advocacy to enhance clinical care. So in 2007, there was an external review. This was really, the concept here was to try to see whether there could be a model developed to bring together the various elements related to a spine, a clinical care, research, education. And then based on that in 2009, the program was established with a co-leadership a model. And then we actually had our first SpineFEST event. Well, this was really kind of building on a concept that Albert Yee had previously developed. And then this evening we'll have our GTA Spine Rounds, and this was taking advantage of something that Joel Finkelstein had brought together. And so the idea was that we didn't want to reinvent the wheel, we wanted to try to take advantage of a number of strong events that had occurred. And then we had our first strategic planning, and then in 2010, it was felt that we wanted to raise greater awareness, that we wanted to have a significant role in resident and fellowship training, as well as a promotion of translational research. And then there was a second external review. We were planning for that in 2013. Then the review occurred, and I think there was also kind of an impetus there to become more involved with advocacy, linking at the national and at the international levels. And so we've had, over the years, quite strong engagement with the Scoliosis Research Society and with the Cervical Spine Research Society, as well as with the AO. We've had a number of important events that have occurred here, of visits from a variety of fellows. And then we, in 2016, included the Tatter-Turnbull Symposium. This was a spinal cord injury symposium that previously had been going on, mainly focused here at the Crumble Neuroscience Center, but we brought this into the University of Toronto a program. Then this was followed in 2017 by a second strategic planning session. And at that time, it was really kind of for the first time, it was felt that there was an opportunity for us to take the fellowship training to a different level, to engage the Royal College and to engage this at a national level. And I just want to give a big shout out to Albert for really showing a big leadership in this area. And Albert will talk about this in a few minutes, because this is, I think, a very big development. Also, Jeremy LaRouche and a number of others have had a significant contribution to this. And then we've hosted a number of big international meetings over the course of the last several years. International Neurotrauma Society in 2018, and then we hosted the AO Global Spine Congress in 2019. And then in 2019 is when we actually applied to the Royal College for to actually have formal recognition of spine surgery as a separate discipline. And there was a lot of engagement through the Canadian Spine Society. And just want to also acknowledge the collaboration of the Canadian Spine Society and Hamilton Hall has had an important role in helping to facilitate this behind the scenes as well. And then a lot of additional events kind of going on over the last several years. And, we've got a little line there, a little event called the COVID-19 pandemic. What a nightmare. But we are actually able to take advantage of this through virtual technologies. And we are actually extremely active during this during this time. And we continued all of our meetings virtually, including having a very robust a journal club, various courses. The SpineFEST event went on virtually as well. And then over the last few years, as we've emerged from the COVID-19 pandemic, we've taken advantage of this to bring on a number of other educational events. We have a fantastic cadaveric spine course that Steve Lewis initiated, and now Chris Nielsen is quite actively involved with that. And then David LaBelle and a number of others have brought on a pediatric spine deformity course as well. And then we've also, I think, the challenges that we face in COVID brought to light issues kind of related to wellness. And so this has also become kind of an important initiative. So we're actually planning for an external review. This will be our third external review, and Albert and I will be transitioning. And we look forward to kind of the new leadership team coming on board. And I think one of the big new initiatives will be this AFC diploma program. And kind of on that note, I'll hand over to Albert.
Good morning, and thank you, Michael. Good morning, everyone. I'd like to welcome everyone to our 16th annual SpineFEST meeting as part of the University of Toronto Department of Surgery. It's really been terrific, as I think Michael has alluded to, in terms of the timeline of our progression over the years. And each year we sort of continue to add additional events as part of our academic program. It's really terrific to see the growth and development of our academic calendar events throughout the year, and it's really been an exceptional, I think, collaboration amongst the many sites around the city, bringing together our clinicians, our researchers, our students, and it's really been a multidisciplinary approach, so we're very appreciative of that strong support. One of the areas that we've really been focusing on, amongst others, and is really the leverage of the expertise within our program. And certainly at the University of Toronto, in the Department of Surgery, there's been a lot of advancements in terms of surgical education, with the changes to work hour restrictions and the evolving I think curriculum, given the increasing specialization of medicine surgery, there's been efforts to advance the educational standards for the recognition of more advanced and training competencies. And so certainly at U of T, we're no strangers to competence by design efforts. And Peter Ferguson and the orthopedic group piloted this quite a number of years ago, and the Royal College has sort of adapted an approach that basically is sort of nationwide for all the medical and surgical specialties. And so a few of us within the university, Jeremy LaRouche, Dr. Hall, and with the strong support of our Canadian Spine Society, basically applied to the Royal College, and sort of pleased to report, the update now is basically the final 3 documents are sort of completed, and they're certainly in version right now being translated from English to French with the Royal College, and this will be available now for fellows in training. We typically host about 13 to 15 clinical fellows around the city, gaining additional expertise, specifically in spine surgery, and mentored by our orthopedic and neurosurgical faculty alongside our scientific team and multidisciplinary interprofessional team. And the fellows will be able to get a designation, including a diploma designation after their 1 or 2 years of clinical fellowship. And so they get a DRCSC designation on top of their sort of base FRCSC. And it'll be applicable for trainees that come from either international or sort of Canadian backgrounds in terms of their education. So we're very excited about that. And there's a few documents that are meant for the trainees, and then the universities will be able to apply this upcoming year through our postgraduate medical education office. And there's already a fairly well supported infrastructure within the university for delivering this diploma program. So we're very excited about that. We've also taken the opportunity, and really as part of an educational and a teaching center and teaching university, really to advance efforts in mentorship and support. And so within the program ourselves, Nadia Jabeur has really been an instrumental figure that's sort of held the program together. It's been a strong foundation for us and sort of progressed to the program manager role over the last a couple of years. And in that as well, we've been able to bring on a few volunteers that I think many of you may have seen at the front desk and sort of taking photos with us, as well as contributing towards some of our evening events this evening. And Delphine Lee basically has been our sort of inaugural mentor. And so thank you, Nadia, for all your mentorship of her. I'm not sure if Delphine's around. If not, maybe we can see if she come in from the front desk. But she's been helping us for the last couple of years, and it's really been phenomenal in terms of her contributions. And we actually congratulate her as she embarks on her own career in medicine in the upcoming year. As part of the efforts, there's a lot of background work that occurs behind the scenes in establishing our day for today. And so I just want to acknowledge and thank the Program Council. There's quite a few folks that helped judge the abstracts. And so Jeff Wilson, Jeremy LaRouche, Megan O'Reilly, Carrie Wine, Arjun Segal, Carlo Amendolia, David LaBelle, Marguerite Akins, Chris Witu, Michael Hardesty, and Chris Nielsen. And special thanks also for Steve Lewis for helping to organize and lead our discussions relating to spine deformity today, and to our key Tatter Hall lecturer for today, Dr. Serena Hugh. A warm welcome. Thank you for taking the time out of your very busy schedule to be with us here today and to celebrate our SpineFEST activities. There's no question that a lot of work needs to be done and needs to continue as it relates to our efforts looking at equity, diversity, inclusion, at wellness, and it's great year over year. I sort of certainly when I travel around the world and various venues and meetings, I really tout how multicultural and diverse the city of Toronto is, but there's no question there's ongoing opportunities, and particularly in surgery, orthopedics, neurosurgery, and our subspecialties certainly have been singled out. And although there are advancements that we're making, there's obviously a lot more work that needs to be done. We've had a variety of sort of wellness initiatives that have been launched as well. And one of our clinical associates at Sunnybrook, Eric Crawford, has been a real champion of this, sort of sharing his story, his journey, and taking an opportunity to regularly meet with our trainees, both informally and in formal sessions, which I think has been quite helpful in support of our program. We have trained over 200 or so fellows. I've mentioned sort of about 13 to 15 fellows each and every year from around the world. About half of our fellows come from international backgrounds, so there is really a lot of impact that we're having globally, alongside the terrific work that our academics, clinician, scientists, as well as researchers are doing in terms of leading, organizing, and presenting at various key national and international meetings. Special thanks to Drs. Carol Swallow from the Department of Surgery, Peter Ferguson, Division of Orthopedic Surgery, Jellery Zadeh, Division of Neurosurgery. They've really been strong supporters of our program for many years, and really without their support, this program would not exist. And in that vein, alongside the university, we do have a variety of industry partners that have been instrumental to help support some of our educational and training offerings. And I do want to acknowledge and thank Medtronic, Dupuis Synthes, Stryker, and Bioventus. So with that, at this time, I'd like to call upon Dr. Carol Swallow, our University of Toronto Department of Surgery Chair, for some introductory remarks. Oh, need my glasses.
Thank you very much, Albert, and thank you, Michael. I really appreciate the opportunity to welcome the crowd here today and bring greetings from the University Department of Surgery, one of your strong supporters. I really want to acknowledge the creativity and determination that former chair of the Department of Surgery, Richard Resnick, showed, I guess, 16, 17 years ago, when he worked with the then leaders in orthopedic surgery and neurosurgery to bring people together who were, I would say, at odds with each other from very many different disparate points of view and backgrounds, and build this spine program at the University of Toronto. It is quite a unique program, as many of you will realize, but some of you may not. So being university-wide, interdisciplinary, inter-hospital, and then interdivision, bridging all of the potential barriers you can imagine that that represents, and being able to work effectively to advance not just clinical care, which is clearly the number one directive, but also research and education. It's really a remarkable program and achievement, and I want to congratulate Albert, Michael, and Nadia on leading this program over many years. As Michael and Albert have both confessed, their time in leadership of this program is coming to an end, but they've really pushed it to fantastic achievements over their tenure, and I think they deserve a lot of credit. Maybe we could give them a round of opening applause. So I would also like to thank the people who've made it possible for this program to continue, which is not just the University Department of Surgery, but also Dr. Ferguson and Dr. Jade in their respective roles of the chairs of the divisions of orthopedics and neurosurgery, and you're going to be hearing from each of them shortly. And then finally, in closing, I would also like to add my thanks to Serena Hugh, our professor from Stanford, for visiting with us. I'm sure she's going to give a fantastic talk, and I look forward to hearing from her. So welcome, and thank you again.
I wonder if we could perhaps hear from Professor Ferguson.
Great. Thank you, Michael. Thank you, Albert. And on the behalf of the Division of Orthopedic Surgery, I want to welcome everybody here today. Welcome to Dr. Hugh. I was just recalling to her that I have a great picture from a couple years ago when she was the first female president of the American Orthopedic Association, in the exact same year that we also had the first female presidents of the Canadian and British Orthopedic Association. So it really was a seminal moment in, I think, in our efforts towards gender diversity in certainly in orthopedics and hopefully in surgery in general. And it's because of your leadership that hopefully we'll recognize that vision at some point. So welcome to Toronto. Hope you have an enjoyable day here. I also want to put a call out to Drs. Tatter and Hall as the sort of the founders of spine surgery in Toronto, and everything that really happens today is because of your vision, and it's great, I'm sure, from your perspective to see it all come to fruition. I had a meeting with Michael and Albert a few weeks ago, and I made the point that every year I get up here and say pretty much the same thing, and that's because I really mean it. Okay, and that's that, as Carol has already said, this group really embodies everything that we should strive for, and is the gold standard of a truly interdisciplinary, interinstitutional, collaborative program. If I could bottle this energy and distribute it to our other divisions, certainly in orthopedics, it would make my job a lot easier. Unfortunately, I haven't figured out that sort of that magic formula as of yet, and I think it's because probably these two are the main reason why this works is their tireless efforts to put aside any sort of siloism and any sort of division in order to fly everything under one flag. So I also want to echo Carol's comments and thank Albert and Michael for all their efforts over the past 15 or 16 years. And also, just want to put a word out to whoever the next leaders are going to be. I really hope that you continue the exact same efforts in the exact same vein as Michael and Albert have set forth for this program, and hopefully you continue to have that as a priority going forward. So best wishes to everybody for a great academic day. Thanks.
Thank you, and I'd like to just call on Professor Galerie-Jade, our Division Head of Neurosurgery.
Thank you, Michael. I'm Galerie-Jade. I'm apologizing for being in less than formal attire. I have to be in the OR. I want to welcome everybody, and especially Professor Hu. Every year there's a remarkable person that's invited as a speaker to the SpineFEST, but this year really is noteworthy for all of the reasons that the previous speakers mentioned. I think I'm going to adjust what I'm going to say because all the comments have been made about the great leadership that started with Dr. Tatter, building the vision for spine, but more importantly, the spine surgeon scientist, but for all of us as surgeon scientists, that dates back to many decades. And then the continued brand that's built, the continued efforts that's been made possible for all of us to be successful surgeon scientists really as possible at University of Toronto. And of course, everybody's recognized the amazing leadership from Michael Failings, from us as neurosurgery, which has set the tone in how we can build partnerships with Dr. Albert Yee on the orthopedic side across the city, providing a roadmap potentially for how we can all work together. I do think then I have to make a note that the reason the program continues and it's sustainable is for the remarkable trainees who come in. And I just want to recognize, I know that we have many fellows, many residents who are surgeon scientist trainees. And really without them helping the engine move forward, everything that we do to help make discoveries, the program wouldn't be possible. So I know from my own experience, nothing I do is possible without all the wonderful trainees that come in, believe in the mission, and really contribute to making the program a success. So there's many of you in the room. I don't know all of your names, but congratulations to all of you actually for providing that next generation of surgeon scientists, in particular in spine. I do see two of our trainees there, so I don't want to call you out by name, but really it's all of your efforts that allows the continued work to happen. Thank you very much for this. I'm sorry I have to run up to clinic and OR, but it's a pleasure to have you here, Dr. Hu. Thank you.
Thank you, Carol and Peter and Galerie, for the kind remarks, and most importantly, for your friendship and support. Just before introducing Professor Hu, I'd like to call on Charles Tatter and Ham Hall to say a few remarks.
I'm speaking on behalf of my dear colleague Hamilton Hall. This is part of the Antiques Roadshow. But it is great that we're still here to enjoy this fabulous event. We have to really pay tribute to Michael and Albert for putting all of this together, and obviously to Nadia Jabber for making it happen. The environment in which we live at the University of Toronto has been so helpful to allow innovations like this one. It was so needed. I remember my days at the Sunnybrook trauma unit when Stan Gertzbein and I decided that we just better work together to make life better for us and for our patients. And I think that's really where it all started. And of course, with Hamilton Hall, with whom I studied for my fellowship and learned all about orthopedics from him, and I think likewise for neurosurgery for Hamilton. And it's been a wonderful relationship over the years that has blossomed into this. However, it wouldn't have happened without Michael and Albert, and we have to really pay tribute to them for making it happen for all these years. So let's give a round of applause to those people who really deserve it. And I think when you think of the beneficiaries of this get-together, who are really the trainees and our patients, and there must be now in the tens of thousands of patients who have been benefited from this arrangement between orthopedics and neurosurgery. So thank you very much and welcome to Serena Hugh. We're very pleased that you've accepted this invitation. Bye.
"16 years, you all know the drill. Charles talks and I stand behind him and smile. So we're not, yeah. Except one year you didn't show up, we had to do it virtually. Dr. Tanner and I go back a long way. He was my senior resident in neurosurgery, which is why I'm in orthopedics. And the one thing I do want to really stress is how different it is today than what it was back then, when neurosurgery and orthopedics were totally different. It was unusual for someone in orthopedics to spend as much time on neurosurgery as I did, and vice versa. Today, you're all looking at a combined program. And for those that have never known it any other way, that seems natural and normal. You have no idea how many hurdles had to be crossed and ditches jumped in order to get to where we are today. And a lot of credit goes, as you've heard so often, to these two gentlemen sitting beside me. Toronto has a wonderful program in spine. It's been around for a long time and it's only getting better. Thank you for being here.
Well, we truly stand on the shoulders of giants, and I think that this it really is an excellent segue to Professor Serena Hugh's keynote lecture. So we're really privileged to have Serena with us, and she's an extraordinarily distinguished and humble a person. She's been a fantastic a friend to us over the last several years, and I think this visit to Toronto is probably overdue. So it's good that we have you we have you here. And I know that when we were discussing asking you to come, it was met with tremendous enthusiasm. So a little bit about Professor Serena Hugh. So she's an American, but she actually has a Canadian connection, and she did her medical degree at McGill University in Montreal. We had an interesting discussion around that. I think she was inspired by some Canadian hockey players at Cornell or something like that. So that was an interesting connection. And this was followed by an internship at Beth Israel in New York, and then a residency at the Hospital for Special Surgery in New York, and then fellowship training in spine and scoliosis surgery at Rancho Los Amigos Medical Centers, which is really, I think, kind of one of the iconic centers in the world for this kind of surgery. And then following this, Professor Hugh spent some time at UCSF, and then subsequently was recruited to Stanford, where she is now the chief of spine surgery in the Department of Orthopedic Surgery, and has a cross appointment in neurosurgery. So Serena has had a big focus in deformity surgery as well as in oncology, and has really had a strong commitment to education, research, patient outcomes. And she's had quite a significant leadership role. She's the first female president of the Scoliosis Research Society, which is really kind of one of the oldest, most prestigious spine societies internationally, and quite remarkably also has been recently named the president of the American Orthopedic Association, AOA, which is a very important international organization in the area of of orthopedics. And you always learn about people kind of when you get to speak with them. And something I learned about last night was Serena's passionate commitment to global health. She just actually recently come back after a stint in Ethiopia, which is really quite remarkable. So Serena, thank you so much for being our 2024 Tatter Hall lecturer, and we look forward to your keynote address, Standing on the Shoulders of Giants, Spine Deformity Treatment Over the Ages.
It's really an honor to be here, and I wouldn't have, despite coming back from Ethiopia and being a little jet lagged, I certainly would have done nothing but say yes. I've always admired this program. I've got a lot of friends in here from Ham Hall. Carrie Wine was, believe it or not, my graduate student back when she was getting her PhD. And then all the people I've known over the years, from Steve Lewis and Raj and Joel, and having met, not quite cross paths with Jeremy, then obviously, of course, Albert and Michael, so I'm really honored to be here. So I had the option of giving this talk on the history of the treatment of spine deformity, and I really think that it's important for us to remember where we came from, not only to appreciate the differences and the advances that have been made, but also to try to avoid mistakes and learn from that history. I also get very sad when I bring up some of my mentors and find out that my current residents don't know who these people are. And I think that's unfortunate because they really made an impact. And so partly to keep their memory alive and also to recognize where we've come from, I think it's important to have history talks, for example. So it's an honor to be here. So here are my disclosures. So you'll be interested in knowing that Hippocrates was actually the first to describe scoliosis and treated this using longitudinal traction as early as 5 BC. Galen then added direct pressure several centuries later into the 2nd century AD, and Paré from France described supportive braces in the 1500s, thinking that the deformity was actually from a dislocation of the spine. In New York, Sayer, who was the first professor of orthopedic surgery in the US, he believed scoliosis was caused by muscular imbalance, so treatment should be aimed at gymnastic exercises. And in 1874, he started treating patients with a plaster cast to correct their spine deformity. Obviously, the management of scoliosis was advanced significantly when Röntgen in Germany discovered X-rays and were able to take X-ray images of these patients to appreciate their deformity. And then, of course, TB of the spine and poliomyelitis came about and also compounded the problem with regards to spine deformity. So early treatment, as I mentioned, was physio. So the picture on the left was considered the keynote position, which, as you can imagine, is basically correcting the spine and having patients develop that strength. And then the trunk exercises here, and I can just imagine us making all of our patients do that sort of a exercise to try to improve their scoliosis. Early treatment was also used forcible correction, literally described that way. And you can see these rather medieval torture type pictures as you see here, where patients were placed in plaster with different mechanisms to apply corrective forces related to plasters, frames, traction tables, progressive padding, and the likes of which were meant to improve the patient's scoliosis. Here's a early publication on a rigid left dorsal curve as described, and over the course of the next couple of months, it shows nearly complete correction of that curve of the spine with use of the Abbott progressive jacket padding. They did not give us long-term follow-up, however. So Russell Hibbs, which many of you know the name of, was a surgeon-in-chief at New York Orthopedic, and he was the first person to describe a spinal fusion. This was in Pott's disease, which you should know is for TB of the spine. And you can see his meticulous drawing looking at how he preserves the periosteum and roughens up the edges and then takes the spinous processes as bone graft. And so this is the first description of a fusion. John Cobb, who most of us know from Cobb Angle and Cobb Elevator, was the first chief of scoliosis at what was then called the Society for the Ruptured and Crippled, which was eventually renamed the Hospital for Special Surgery. And he used a turnbuckle cast and staged his spinal fusions to get more bone graft in there. And he was probably the first to describe scoliosis as being, you don't have to be crazy to do scoliosis, but it helps. And I think a lot of us still relate to that description of the management. And this is a patient treated at the Ruptured and Crippled. He's a 14-year-old. There was a gentleman, a surgeon named Albee, who actually learned from his uncle, who was a tree farmer and used struts. And this was a strut graft used to help support the spine and create a fusion with the correction that you see here. So treatment in those days didn't advance much from the ones that you saw earlier, but this required pre-op casting, post-op casting, and bed rest. So sometimes I'm tempted when I tell patients what we do to them now, I feel like saying, well, this is what we used to do. We've come a long ways, and it could be a lot worse. So they were in cast for a long time, they were in traction, bed rest was fairly standard, and I've met a number of patients who were managed in that way and written books about it, and it was really a traumatic time for many of these patients who were treated for their scoliosis. So the first publication was actually presented at the AOA and published in JVJS in 1941, and they had 425 cases. You can see Shands is the lead author on that, as well as Joe Barr and Paul Colonia and Paul Noal. And 50% of their patients went on to fusions because they'd failed conservative treatment. And you can see the different ways that they were treated for conservative treatment as well as for fusion. And they were honest enough to recognize and report that they only had 31% good to excellent results, and 69% had fair to poor results. So that's certainly not a vote of confidence for the management of treatment for idiopathic scoliosis. Joe Risser came along, and most of the people I've mentioned up until now have been on the East Coast of the United States, but Joe Risser was from LA, and he was a protege of Russell Hibbs, and he described what we now know as the Risser sign in 1958. And he designed the Risser cast, where you can basically apply forces and have the patients up and about, and they would cut out these reliefs to improve the scoliosis, as you see in the x-rays here. Walter Blount from Milwaukee designed the Milwaukee brace, which included immobilization of the cervical spine. This was originally designed for post-op polio patients to try to correct their paralytic curves. But then in 1959, he adopted this to treat non-operative adolescent scoliosis patients. But unfortunately, because these patients were quite young and because the forces applied, even around the jaw, this could cause mandible deformities, and so largely has fallen out of favor. John Moe is certainly the grandfathers of scoliosis management and scoliosis surgery, and he founded the scoliosis surgery service at Gillette Hospital in Minneapolis. He was the founding president of the SRS, which I'll get to in a minute, and he used a combination of different techniques and different experiences and used the Risser localizer cast, the Milwaukee brace. He's credited by John Hall with convincing Harrington, who I'll get to in a second, that a fusion was needed with his rods. So Harrington originally thought he was going to use his Harrington rods without a fusion. And he published in 1958 a fairly remarkable 15% pseudoarthrosis rate if you think about the prior reports. And so with all these combined techniques, he was able to get up to an 85% fusion rate. So some of us older folks in the room remember the Moe textbook of scoliosis, and originally published by Moe, and then this is the third edition that you see on the far right. Nobody has textbooks nowadays, but it was considered a great honor to have a copy of this, and we used to give them to our spine fellows. So this is a picture of the founding group of the Scoliosis Research Society, and this is a fairly famous picture for those of us who belong to the SRS, and this is in June of 1966. And interestingly enough, the idea of the SRS came from David Levine, who was one of my mentors at SRS. He was a fellow, interestingly enough. So fellows can come up with groundbreaking ideas, so don't be afraid to speak up. And he was struck by the fact that people on the East Coast and the West Coast didn't talk to each other. And so here you have a fairly difficult problem to manage, and nobody talked to each other about how they manage things. And so he suggested a club, which became the Scoliosis Research Society, and it might be one of the earliest subspecialty societies that I'm aware of, as you see here. So this is a bunch of I'll have my diversity pitch here, a bunch of white men, and you can see the one female is Jackie Perry, who was at Rancho Los Amigos, where I did my fellowship, and I did get to meet her after she'd stopped doing surgery. So one of the interestingly, the early focuses of the SRS was M&M. And so this was the early punch cards that was used to collect data for the SRS. So SRS members are required to collect the data on their complications, and that's part of a membership requirement. And this punch card was submitted by all the members for each of their cases. And at first, they basically collected on neurologic complications as well as death within 1 year. But this is the kind of data that collecting and pooling data, which we all know nowadays with registries and things, allowed them to realize that the stretch of the spinal cord was a cause for paralysis and recognize the importance of the artery of the Debkowitz. Nowadays, we've gone to a computerized app, so we've come a long ways from these punch cards. So Dean McEwen was the chief at DuPont Institute, and he's pictured here with Yves Cottrell. And in the late 1960s, one of his patients at DuPont refused a Milwaukee brace, imagine that, despite what he describes as extensive counseling. So he designed the Wilmington brace, or what is now known as a TLSO, where the patients had a custom-made brace with the corrective forces applied, and they designed a cast and then the brace from that. So that obviously had much more acceptance than the previously used Milwaukee brace. This is a book on the work that Harrington did, and this was written by Mark Asher, who received Lifetime Achievement Awards not only from SRS but also from POSNA. And he put together all the work from Paul Harrington because the Harrington papers reside at University of Kansas. And it really was a labor of love because of his dedication to the history of scoliosis management. So Paul Harrington presented in 1966 a instructional course on scoliosis and instrumentation. And this is really the first time that instrumentation was used in the spine for scoliosis, unless you count that little strut graph that Albie put in years ago. He had the forethought to talk to Mel Glimsher about the structure and organization of bone, and he also visited Enneking, who you might remember is a pathology and tumor specialist in orthopedics, and to discuss histology. Interestingly enough, he was very resistant to using autograft bone. He wanted to use bovine bone, and he actually set up a processing center to minimize the reactivity across species to try to use bovine bone rather than harvesting from the person themselves. And as early as 1974, he was actually looking at titanium vanadium testing. So he was looking at metallurgy, which is something that was clearly important in designing his instrumentation. So the book is really fascinating, so you have a chance to get a hold of that book. Dogged Persistence, there's a lot of diagrams originally done by Harrington, and you can see the original design was this hook here with a ratcheting device to distract in the spine, and then they had a self-adjusting spine strut there, and then there's actually the Harrington Fusion, where you can use the Harrington outrigger was used to apply correction, and then you could apply the distraction force, and you can see then you can see the struts placed over that, the bone graft. I thought it was interesting to point out that there was a note on the royalties were a fixed payment, so that a distraction compression 8-hook construct cost $59 in those days. Can you just imagine that? I don't think we can get a set screw for $59 alone, a whole construct. And the royalty to Harrington was 3% or $5. It did not adjust for inflation, and Zimmer had the exclusive rights, interestingly enough. And so in 1 year, Harrington received about $3,700 in royalties, which was probably a lot of money in 1962, but still nowhere near what people get for royalties nowadays, even with, if you go to current dollars. And there were no patents. In those days, a lot of his funding was from the National Foundation, so he didn't feel he deserved a patent. He thought it was kind of public domain, similar to the Salk polio vaccine. So Harrington really didn't earn very much from his really landmark invention. And some people don't know this, but he actually was the first to design pedicle screw instrumentation for spondylolisthesis reduction. He, as you can see, he put a hook across the pelvis to try to reduce that, and so it didn't really help with kyphosis. But again, first person to use screws for spondylo reduction. So David Levine, who I mentioned was one of the founders of the SRS, applied the first Harrington rod at HSS, and you can see that that was a fairly big deal because the patients had to be in traction, get their casts applied, and you can see the results below, where in 1967, the patient had a double major curve, the patient had 2 distraction rods, but 40 years later, the fusion is intact, and the patient was doing well, and actually came back to Dr. Levine to show him their twin children when the patient was older. So a nice follow-up on that patient. Alan Dwyer was a surgeon from Australia, and he visited Arthur Hodgkin in Hong Kong. And so many of you know that in Hong Kong there was a lot of TB, and so a lot of treatment of TB was out of the Hong Kong area. And because of the work that had to be done in the anterior spine, Dwyer thought of the idea of excising wedges from the anterior spine to try to correct scoliosis. He published this in Clinical Orthopedics in 1969, unfortunately died early, and but the use of instrumentation in the anterior spine was the first promoted by Dwyer in those days. Zilke one-upped him in some ways and improved upon this, where he designed a threaded anterior rod. He's obviously from Germany, and he used nuts that could be adjusted repeatedly to apply corrective forces, and actually had an outrigger that helped with the derotation of the spine as well. And John Hall and Lyle McKaylee presented Dwyer with a solid titanium rod to allow him to have more rigidity in that construct. And for the young people in the room, it might be interesting to note that he was the last resident interviewed, and he had to do scoliosis because that was the only rotation left. Okay, so he obviously used that to his advantage. He was not allowed to use Harrington rods at his first institution, but then he moved to another institution, Mannheim, and required that was allowed. And then he was actually encouraged by Dwyer to improve the system, and he was one of the early people to recognize sagittal contour and the importance of not creating kyphosis in the lumbar spine. So John Hall actually started at Hospital for Sick Kids here, as I think most of you know, or many of you know, and he was president of the SRS in 1969. For his meeting, pulmonary function was a focus of that meeting, and that's something that was not recognized until close to that time. And he realized that patients who were had the shorter trunk because of their scoliosis, they should use the patient's arm span to determine what their normal pulmonary function should have been. And this particularly applied for curves over 60 degrees. And he reported on 32 patients with Dwyer instrumentation, and his philosophy was to overcorrect the lumbar curve so the rest of the spine would straighten out more, and that was how he addressed lumbar curves. And so he was certainly instrumental, and later went on to receive the Lifetime Achievement Award for the SRS for his work. So Pierre Stagnera was obviously French. This was actually the only picture I could find of him, but this is a very French picture, so that was very appropriate. And he actually had previously established an organized non-surgical approach with casts and braces that he called the Lyonnaise School, which I always thought sounded more like a cooking school than a scoliosis school, but was working on exercises and things for his patients to try to improve their curves. And he was an early treater of adult deformity, and so because of that, he needed to have a safer way to address the curves and avoid neurologic deficits. So he actually was the originator of the wake-up test, the Stagnera wake-up test, and he presented on this in 1972. He also recognized the kyphosing nature of scoliosis and the 3D nature. Another thing that's named after him is the Stagnera view, which is, so if you have a patient that's very, very curved and rotated, if you take an AP of their spine will be rotated out of plane. So to get a full view of the magnitude of the curvature, you need to take an AP of the spine. And that'll really change your curves, especially if they're over 90 degrees or so. So Les Nash, who ended up in Cleveland, was the pioneer on spinal cord monitoring. And he did experiments on cats and was able to show the role of blood pressure and cortical evoked potentials. I was actually one of the traveling fellows, and he was a senior traveling fellow. The SRS has a traveling fellow where you have a senior person with you, and he was our senior person. You can see I'm the short person in the middle there, and this is Les kind of in the bottom front left on the picture there. And several years later, he, with Winter, Simmons, and Dixon established the Harrington's guest lectureship, which is a keynote part of the SRS meeting. Eduardo Luque was a Mexican, and up until now, patients had to be in a cast after surgery for a long period of time. But in Mexico, that doesn't go over very well because the patients it's hot and humid up there. I realized when I put this talk together that I have a lot in common with him, since he spent time at Stanford, McGill, and LA Orthopedic Hospital, and he designed these sublaminar wires for segmental spinal instrumentation, which allowed for multiplanar correction and also allowed patients not to require postoperative immobilization. So clearly important in a hot climate such as Mexico, and helped advance the understanding of segmental instrumentation. So it's starting to be recognized around that time that with distraction instrumentation, you would lose the patient's lumbar lordosis. And that clearly creates flat back, and something we now very well appreciate. So in an attempt to try to avoid this problem, Mo invented the square-ended hooks, so the rod would have a square end, and so thereby not rotate around, and hopefully you could build in lordosis for the patients if you had to fuse to the lumbar spine. And so that was part of an attempt to avoid that problem. One of the other great steps forward was by Howard King, who was a fellow with the Minnesota group at that time, and they published on the King-Mo classification to try to avoid fusing too many levels in thoracic scoliosis. And so they designed a 5-part classification scheme and published on their 29-year experience, and found that using their classification scheme, they only needed lumbar fusion in 13.9% of their patients. So really avoiding fusing the lumbar spine in a number of their patients. And this was clearly a step forward in allowing surgeons to do a selective fusion. A major step forward was CD instrumentation, and this was brought in 1984 to the US. So this is kind of the beginning of my part in this. I finished at McGill in 1984, so I started my residency in 1984, and so CD came to the US around that time. And this allowed for multiple hooks to be placed at fixed points along the rod, and you could derotate the spine, distract the spine, and compress the spine. So you can think about derotating the spine, distracting in your concavity, compressing in your convexity, and getting three-dimensional control of the spine that way. It was rigid and stable enough to eliminate bed rest in a cast, which is obviously a big plus. You didn't have to put a sublaminar wire in the canal next to the neural elements, which obviously is a big downside of the Luque wires. Unfortunately, the construct would cost $3,000 for a typical CD construct versus $300 for Harrington rods. So a step forward in technique and technology and advancements for the patient, but adding technology sometimes does increase cost. So the next step forward was the Isola system, which was designed by Mark Asher, who I showed earlier, and he added the ability to add screws to the system. And so in that time, basically all the screws in the lumbar spine had been placed with Steffi plates. So Arthur Steffi was a lumbar degenerative surgeon, and he would put Steffi plates into spines for fusing degenerative disc disease, and Mark Asher's work in incorporating that into his deformity system was the first step forward, using screws in deformity management, such as you see here. And he published on his results in 2004, and had up to 12-year follow-up on his patients with a remarkable 2.2% pseudoarthrosis rate. So that's pretty impressive, with excellent curve correction and trunk rotation correction. So obviously with more powerful instrumentation and wanting to go beyond to just classifying thoracic curves, there was a need to classify all adolescent idiopathic scoliosis. And so Larry Lenke and the Harm Study Group looked at these categories. And so they had 6 different categories of curve types. And you can see there's different structural versus non-structural parts of these curves. There's a lumbar modifier for how far the lumbar spine deviates from the midline, as well as a thoracic sagittal profile. And this tells you, or gives guidelines from the standpoint of which part of the spine needs to be fused and which curves need to be corrected. And this is pretty widely used nowadays, essentially for everybody who's treating AIS, and obviously applies quite widely within the AAS group. However, the next step forward, a lot of people were trying to avoid fusions in patients because, I don't know about patients here in Canada, but in the US, fusions are an F word. Nobody wants a fusion. And so certainly for patients that have residual growth remaining, there is the opportunity to use their vertebral growth with growth modulation. And so John Braun and James Ogilvy looked at a goat model and created scoliosis with a posterior tether, and then were able to correct the scoliosis with a shape memory metal staple, which allowed the concavity to grow, but arrested growth in the convexity, such as you would use in the knee for any sort of growth arrest. And so they had nice results in the goat model. And then Peter Newton moved on to using cables and tethers in the spine. And so one of the recent advents within the pediatric literature, and I'm sure Steve Lewis and the other pediatric spine surgeons have more experience with this than I do, but that vertebral body tethering for patients who are still growing with idiopathic scoliosis can avoid fusion in those patients, allow the patient's growth to be harnessed to improve their curve on their own. Unfortunately, they found that of their 11 initial patients, 2 of them were overcorrected and required adjustment or loosening of their tether. It didn't correct the rib deformity, and it's contraindicated for kyphosis because it tethers anteriorly and prevents growth there and would aggravate the kyphosis. And so I think people want to avoid fusion, and so there's always the question of whether there's fusionless surgery is the future. And we do try to please our patients. We try to avoid fusion where possible. But we tend to stretch the indications, and I think for AAS kids, we're actually narrowing the indications for tethers rather than expanding them. And unfortunately, some failures will certainly occur and increase, and we definitely need to have a better understanding of materials and a better understanding of spine motion with these tethers in place, and also a better understanding of older spines, adult spines. So unfortunately, tethers are touted as being the be-all and end-all for certain patients, but you can see that tethers are definitely not the answer. And I can unfortunately show you a few cases where the tethers caused a worse deformity than they prevented or were originally treated. So another important advance in the management of spine deformity is neuromonitoring. So remember I mentioned Les Nash had worked with cats and they could do SSEPs, but that's not what obviously the patients aren't happy if they're numb, but they're really unhappy if they can't move their legs. And so we would often do SSEPs with a wake-up test, which is disruptive to the surgery, and anesthesiologists don't like it. And it's also a limit on how often you can do that. So the ability to do neuromonitoring with the motor evoked potentials was definitely a big advance in the spine world. And this is something that we started doing probably in the late 90s more commonly, because these are the papers, but it took longer to get good techniques and general reliability for this. So that was certainly something that made spine surgery and deformity surgery a lot more safe for the patients. And Michael mentioned that I was just in Ethiopia, and although the surgeon before me had gone to Ethiopia and done surgery for 8 years prior, this is the first year we had neuromonitoring. And you can imagine my stress level last year when we didn't have neuromonitoring, not even a wake-up test. It's a lot, I don't want to say easier this year, but at least we had a little bit more of a margin of error this year. So adult scoliosis. So John Costwick is certainly one of the giants that came through Toronto, and he served as president of the SRS in 1987, founder and president of NAS, and then founded his company K2M in 2004. And he was one of the early people to focus on adult scoliosis as opposed to idiopathic teenagers. And one of his many innovations was the problem of proximal junctional kyphosis and using PMMA to augment those ends to try to prevent that from happening. And he published a number of papers on the management of adult scoliosis. Thoracic pedicle screws then came into, I don't want to say popularity right away, but Dr. Suk from Korea actually presented to the SRS, and those of you who were there remember these x-rays going up where you just see, it looked like somebody's dartboard where there were K-wires all over the place, and you'd be looking at these x-rays saying, where are those K-wires? And presumably the patients could still move, but they were thoracic, there's his sites for thoracic pedicle screws. And he showed in the early 1990s that if you had hooks, you could get an average of 50% correction, but with segmental screws, you would get 72% correction, because the screws, the pedicle, obviously are much more powerful. They work through all the columns of the spine. You can rotate the spine more and translate it more, and so it really added to the power of your correction. And he published this in 1995 and really has changed the way we treat adolescent idiopathic scoliosis and even adult idiopathic scoliosis, although obviously has a higher risk for many of our patients. Because of this, we needed to learn more anatomy about where to place those screws. I think most of us would know where to put lumbar screws, pedicle screws in, but thoracic anatomy is a little different, and so the freehand technique requires memorizing all these points to use to be able to place a pedicle screw safely in the thoracic spine. And so moving on to more in the adult spine. So many adults may not have just an adult scoliosis that hadn't been treated, but also degenerative scoliosis, and they're more likely to have lumbar degenerative problems and need to have fusion to the pelvis. And a lot of the fusions to the pelvis early on had a high failure rate, with up to half of them having failures because of difficulty achieving fusion. You can see in this picture here, you've got screws at the bottom, and the sacrum is a pretty small bone. So just relying on all your fixation to teeter on the sacrum is not really a good recipe for success. And so we borrowed from the neuromuscular literature, where the Galveston technique, where you can place rods into the pelvis to get better fixation than just screws, was the first step towards that, and that's what I did a lot in the beginning of my career. But then some people smarter than me realized that you could actually place screws to the same trajectory. And so pelvic fixation or iliac screws could be placed. And they did a biomechanical study which showed, not surprisingly, that if you get the anterior part of your screw anterior to the weight-bearing axis of the patient, you're going to have a better resist cantilever forces better than if you have pedicle screws in there. And so that was an important step forward from the standpoint of adult scoliosis in particular, but any sort of pelvic fixation. And since that time, more recently, Sponseller and Kabesh realized that you didn't have to go way out laterally to the iliac crest, but you could actually get to the iliac crest from the sacrum. And they based this on the CT scan of a number of young patients. And you can see that the pathway through there is fairly straightforward. You can do this through with fluoro imaging. You can do it through anatomic imaging. And sometimes, however, you can do it through ORM navigation, which is another step forward, because the trajectory sometimes isn't as predictable as you'd like it to be. So BMP was a big advance for the spine world. As most of you know, it was discovered by Eurostin way back in 1965, but it wasn't really manufactured to any extent until the early 2000s. And BMT7 or OP1 was released in 2001, and BMP2 was released in 2004. And it was, the original indication was actually the anterior spine. And so that's something that really took off. The first year that BMP was introduced, I don't remember how many millions were suddenly added to the budget of our hospital, but we've had to cut back because it isn't the be-all and end-all, but certainly, and can hide a lot of faults in our fusion technique as well. But one of the ways to avoid pseudoarthrosis is not just good instrumentation and good fusion technique, but also interbody fusions with a separate approach. And these people at WashU, including Larry Lenke and Keith Bridwell, showed that you could basically do a posterior-only approach with BMP and achieve similar fusion rates as if you did a combined approach. So that's pretty much the standard treatment that many people who come through WashU do. So you have a kind of a division of people who do posterior-only procedures and combined procedures, depending on how much you want to rely on your BMP. So Ed Simmons was a well-known surgeon who came through Toronto as well. He was CSRS president and SRS president, and he was really one of the first ones to do major corrections in patients who had severe deformities. And so most of you haven't seen patients with ankylosing spondylitis who are poorly managed because the medical management is so good nowadays. But once upon a time, you had patients that would walk around looking at their knees or looking at the floor, and it was very disabling. And so one of the problems was not just how to do the surgery, but also how do you position those patients, because you can imagine on a typical operating table, there's not a good way to get that patient positioned. So Dr. Simmons actually designed and realized that you could operate on these patients sitting. Okay, and you can see the picture here of how he would do that. And then he would do a laminectomy and reposition the patient and actually crack the patient's neck. And so you can imagine that would be a little bit gutsy, to say the least, the first few times you did that, let alone for the rest of the time. But he was able to achieve excellent correction of that deformity and really give the patients their lives back, assuming there was no neurologic compromise. And so that was really an innovation and really kind of set the scene for people being more aggressive about correcting major deformities, as you can imagine. And so other major deformities include, for example, in the thoracic spine. So my mentor, David Bradford, as well as Ohana Babawachi, who worked with him in Minnesota for a number of years and has actually now gone back to Ghana to run his hospital there. So what's considered a complex deformity in this realm is a patient that if you overcorrect one curve, you'll end up creating another deformity. So if you look at the X-ray, the drawings here, if you corrected the patient on the left, their thoracolumbar curve, you would make them more decompensated. But if you corrected the thoracic curve, you would make you might make the shoulders off. So if you, by correcting, you can't get them harmonized or whatever. So the way to do that is actually to do a resection of the vertebral body, so you can basically realign the spine. And as I mentioned, this was first performed and published by Bawachi and Bradford back in the early 1991, and they got excellent curve correction at 43%. So this is my first VCR. I actually did this, thankfully, with Dr. Bradford. And you can see that if you corrected her lumbar curve, you'd make her shoulders much more oblique. If you corrected her thoracic curve, you'd make her more decompensated. And doing both in the middle, you can't really predict. So we did a resection and got a nice overall coronal alignment, as well as her shoulders being better, but not perfect. And I've actually seen her back recently. She's actually doing quite well. I think I saw her like 5 years ago. So nowadays, a lot of things, as I mentioned, are done from the posterior only. And Suk of thoracic pedicle screw fame reported on his results with a posteriorly based VCR. And so he had a number of patients with complex deformities, and he reported on 70 patients. He had 2 cord injuries, 4 root injuries, and 5 fixation failures. And in his text, he wrote that this was technically demanding and exhausting. And I don't think I've usually seen exhausting in a publication before, but that was an honest opinion. And the Koreans, as you probably know, are a fairly stoic group. So if they say it's exhausting, they mean it's really exhausting. And so this has gotten increasingly popularized, and it's done fairly, I don't want to say commonly, but for complex and severe deformity. But there are still significant risks. Linke published on his papers on his 43 cases and had 18% that had neuromonitoring issues, 4 of which had residual root problems with eventually resolved. It's important to select the levels to be resected, and it's important to have at least 3 levels above and below bilateral fixation. Navigation can be used if you have access to that, but it does allow you to correct complex deformities, and it does require rib resections if you're going to do this in the thoracic spine. So this is a patient who'd had 18 operations before this point in time. You can see kind of the jumble of instrumentation that she has here. She's decompensated to the left, the right, and also can't stand up straight. So we did a resection right down at L5, and got her corrected back. Not perfectly coronally balanced, but sagittal is the most important part. You can see the cages down at L4 and L5 touch each other, which limited our correction, but she was much more pleased than she had been coming into me. And so the recognition of sagittal balance, I mentioned, is really, really important and really has advanced our ability to treat patients properly. And this was first published by Glassman in 2005, where he showed that the patient's radiographic parameters and the loss of lordosis was more predictive of their clinical function than any of the other parameters in what they looked at. And so partly an outgrowth of this, Frank Schwab and the ISSG group published what became known as the SRS Schwab classification, where the important part is looking at the 3 sagittal modifiers, where the PI compared to the pelvic incidence, which is a measure I'll show in a second, compared to the lumbar lordosis, the global alignment, and the pelvic tilt. All of these are graded, and depending on how severe the grade is, the more loss of function the patient has. And I'm definitely a lumper. I'm not a splitter. I don't like to measure things if I don't have to. But what got my attention with this is you can see that, so the pelvic tilt is a measure of the patient's retroversion of their pelvis. And if you can change the patient's need for retroversion, it does impact the likelihood that you're going to reach the MCID. Okay, if the sagittal vertical axis, which is a plumb bob drop from C7 compared to the back of the sacrum, and again, if you can change your SVA grade, it impacts the likelihood of reaching the MCID. And the kind of the foundation of all of this is the match between the pelvic incidence, which is a measure of the pelvis relative to the hips in space compared to the lordosis. And if you change that, the mismatch grade, it has the most impact on the likelihood of reaching MCID. So this is why I said, okay, I can't ignore this. I really have to pay attention. And I think all of us recognize that getting the patient sagittally balanced is really the most important step from the standpoint of the patient's outcomes. We also know, and we're not yet sure how to do age-adjusted sagittal balance because my 60 is not your 60 or our patient's 60, and life is a kyphosing event. So unfortunately, if you overcorrect them, they will get kyphosis above, what we call reciprocal change. If you undercorrect them, they're still going to bend forward. So you know where your target is very key. So how you adjust them from an age standpoint is very important. And then you have osteoporosis, and then you have the physiologic norms and the role of fragility. There are neurologic confounders. And then what about patients that have hip arthritis or hip contractures? How do you take that into account when you decide what your surgical targets might be? And so we're looking, I think all of us are trying to figure out how to adjust these parameters physiologically, their frailty, their muscle mass, neurologic, their osteoporosis, their function, their genetics. And every decision or choice we make along the way has a consequence to the patient's outcome and the selection of what we decide to do. So the future, certainly in potentially precision medicine, we hasn't gotten there yet. Some of you remember we went through a phase where we were testing patients for genetic risks of scoliosis progression, the SCOLI score. And so if the patients fell in the green area, they had low risk of scoliosis progression. You didn't have to brace them. If they were in the orange area, then they'd probably progress, and either you wouldn't bother bracing them or you'd tell them that they needed surgery. But there's a huge gray area there. So that really didn't help very much. And since the genetics were taken from Caucasian teens in Utah, it turns out it wasn't very widely applicable after all. So there's multiple candidate genes being evaluated that are presented each year at the SRS. But clearly the key is early diagnosis, potentially molecular diagnosis, bracing when high risk, and other non-operative treatments that might yet not have been designed. So we've come a long way from this is what I did when I started to this is what I might do now for an adult scoliosis patient. Certainly the ability to avoid surgery in these patients might be even better, or to do a shorter fusion if possible. But we still have room to improve. So thank you very much for your attention, and I appreciate being here.
Serena, thank you. It was a fabulous, fabulous lecture, really kind of outlining the tremendous developments that have occurred and, you know, our assessment, the technology of spine and specifically in spine deformity. So we have some time for questions. Steve Lewis.
So, you know, in Toronto, we haven't really adopted fusionless surgery yet. And is that something that we are behind the ball? I haven't found it. We do a little bit of growing rods and things like that but for the tethers and things, it's something that we haven't adopted. Is it something that do you think there's a future for? And do you see it changing the way we do surgery in the adults in the future?
So that series in a little bit to be controversial because it is something that is touted as kind of the next big wave. I didn't really bring it out enough, but I think that the indications are narrowing, not widening. But there are people out there that are widening it further than I think is appropriate. And I think that's part of the problem is that it's like you've got a hammer, everything becomes a nail until you realize that you're smashing your thumb every time. And so I think there's a role for tethers which will be fairly small in the growing child. I don't yet think that we understand what it'll do in an adult. And I think that like the patient that I showed is now 23, and that progression happened in their 20s. So I think there are a lot of things we don't understand about it, and we're going to create a lot of problems if we just go down and think everybody needs a tether. So I think the conservative route is what I would prefer if it were my child, or if I were doing a lot of tethers. I don't see many young kids enough to be candidates, but I think, again, you need them young enough to have enough growth, not so old that they have too much growth, not so young that they have too much growth, and it has to be a flexible enough curve. So when you narrow the indications down, I think it's probably overutilized in a lot of people's hands, and we're just trying to figure out where it belongs. But I definitely think that you'll be glad that you did not jump on that bandwagon rather than saying, I wish I'd gone there earlier.
Serena, what is the current role of bracing in the management of like children with kind of a less severe deformity, and at what stage do you think that that surgery might be indicated? Has that changed at all over the years, or has that sort of stayed constant?
I think bracing has been established through several studies, most recently Stuart Weinstein's BRACE study, that bracing does work. But it doesn't, one of the problems is that there are some patients that will progress regardless of bracing, and that can be hard to predict. So the teenagers that I have that are progressing or at risk, I will still brace. And most of them will have a good result. Now, whether or not they will have gotten there without the bracing is hard for me to know, but the data suggests that I'm preventing a reasonable number of them to progress to need surgery. I think that it's hard when you have a patient that's kind of in the cusp of whether or not to have surgery, because the kids maybe don't want to have a brace and they want to move on. On the other hand, if you just brace them at night, they're more compliant. I think there is a certain element of bracing because it's the only thing we have to offer somebody, and just watching your kid get more curved is hard to imagine. But it does work in a high enough percentage of patients that it's worth doing and worth offering to people.
Carrie?
Thanks so much for this. I'm just wondering, so what would you say is our next, what should we be focusing on as scientists, as engineers? Where is the next big thing in technology? Is it materials? Is it pre-op planning? Is it applying machine learning to hordes of data that have been collected over the years? If you were going to say, well, this is what we need to address right now, or is it biologics and genetic, other types of applications?
Yeah.
What's the number one or two priorities that you would say we need to start looking at?
I think that's a really tough question, but it's a really good one. I think being able to prevent progression in an adolescent idiopathic would be the biggest one. Like if you could get all those kids to stop progressing. So is that going to be genetic manipulation or predicting who's going to progress? I don't know where it's going to be, but that would be kind of the holy grail, is like, where can you figure out how to avoid those patients needing surgery, or in their, right now, the pediatric world goes up to age 18 or 21 and the adult world takes over, but in their lifetime, just delaying their surgery so they get it, so that they skip over the pediatric people and come to me, that isn't necessarily an advantage. It just means kicking the can down the road. So if you could avoid if there was some way to modify the proprioception, for example, of those kids. And there have been tests trying to do that, or identify who's at risk. That would be kind of the ideal thing, is just avoid those kids ever getting worse. From adult standpoint, we're trying to figure out, more about understanding frailty and risks and those kind of things. But I think that's kind of the cat is out of the barn. It'd be nice if they never had a deformity to begin with. And part of it is, it might be being as sedentary as we are. We're not as active. It might be the fact that the neglected idiopathic curves, for example. There might be a way to, like degenerative curves, they're degenerative because the disc is wearing out asymmetrically, for example. Is there a way to prevent that degeneration happening? You know, so some of the disc repair work might be in there. So it's all kind of there's so many different factors that go into it, and so there are different ways to potentially improve or avoid needing. I don't necessarily think that putting in more hardware is the better idea. I think basically avoiding them getting to need the hardware is the better idea. So thanks.
Jeremy?
That was a fantastic talk. The only thing I miss is where Dr. Lewis was sitting in that picture of the founding fathers of the SRS, but you'll point it out later.
He's not old enough.
What I was wondering is, in that growth in terms of the learning curve from where we are now to where we've been, how much of it is knowledge versus technology? And the vein in which I ask this is, when you're traveling to Ethiopia and doing scoliosis surgery, are you able to achieve 100% of what you do in Stanford, or is it 80%, or where are we in terms of that, you know, that idiom between having the right tools versus the right knowledge?
One of my pet peeves is technology over reason, and I kind of alluded to having a hammer and wanting to have everything be a nail. I put screws into more curved patients in Ethiopia without navigation than I would ever think about doing in the United States. You just have to kind of know the anatomy. And so I think technology is part of it, but technology is a way to apply knowledge in a way, so I don't think you can totally separate it, right? I think the fact that we can do neuromonitoring better is both. It's knowledge and technology, right? And knowing how to get bones to heal with BMP. It's expensive, it's technology, but it's also the knowledge of how to get the bones to heal. So I think they're related, and I think there are some parts that I think just, it's like throwing more hardware at something, like throwing more money at something to do it better isn't necessary. You have to understand why it works and make your substrate work better, not by putting more BMP in there, but giving it a better environment. So I think they're related and they're not necessarily separate, but I think you need to know both to be able to do the best for your patients. Thank you.
Thank you.
Yes. Serena, thank you for that fantastic talk. Really a tour de force. It's really kind of remarkable to see the evolution of complex spine surgery. And I really like Carrie Wine's question, right? You know, where are we going to be going? We still don't really understand the genetics of this condition as well, right? So just, you know, what is the actual cause of this from a developmental perspective, which would be amazing if we could have insights into that. So we have a couple of sessions that we've called elevator pitches, and this is where we ask our trainees to come up and just give us the quick kind of succinct elevator pitch. So if we can kind of have our trainees kind of coming up here, and we'll hear from Ahmad Essa first. And then Arman, if you can kind of come up here, we'll just sort of come up here very quickly. We'll hold questions till the end, okay? So go ahead, Arman. Okay. So very quick.
Okay, how do I? Yes. Hi, my name is Ahmad Issa. I'm a spine research fellow at St. Mike's. A tracheostomy is a common procedure performed in a complete cervical spine cord injury patient, as 80% of these patients may require a mechanical ventilation. Past evidence has showed that early tracheostomy offers significant benefits for this patient. So our goal was to evaluate the influence of surgical approach on the association with the tracheostomy timing. Does it keep the same benefits regardless of the surgical approach? To do so, we have conducted a retrospective multicenter study using the TQIP data from 2017 to 2020. The main outcomes were in-hospital complication, immobility complication, surgical site infection, a hospital and ICU length of stay, as well as a ventilation duration. For each of these outcomes, we have constructed a multivariable adjusted model accounting for up to 20 different variables pertaining to patient, injury, and hospital. The exposure was a surgical approach in which over 900 patients were treated by posterior approach and 670 patients treated by anterior approach. And using the previously mentioned adjusted models, comparing early to delayed tracheostomy while accounting for the surgical approach, we can see that early tracheostomy kept its benefit with reduction in in-hospital complication, immobility complication, ICU and hospital length of stay, and days on ventilator. So early tracheostomy for patients with traumatic complete cervical cord injury is associated with reduction in outcome, reduction in complication, length of stay, and ICU length of stay, regardless of the surgical approach.
Thank you, and we'll hold questions until the end. Thank you, and we'll. The next speaker is Arman Malhotra.
All right, thanks for the opportunity to be here. We looked at a Canadian cohort through the Canadian Spine Outcomes Research Network, identified 800 patients undergoing surgery for degenerative cervical myelopathy. Our question at the outset was, what is the influence of perioperative adverse events on outcome trajectories? And really the challenge with looking at perioperative adverse events is the heterogeneity. So this data set, it captures these variables using the SAVES version 2 spinal adverse events outcome scale, which is a validated and standardized method of categorizing the severity of perioperative adverse events. So what we did is we categorized minor, major adverse events and no adverse events, and we showed that about 5% of patients undergoing surgery for DCM experience a major adverse event, and really that influences both the MJOA outcome trajectory up to 2 years, which is what we had appropriate data to look at, as well as NDI trajectories and other patient-reported outcome trajectories. So really, this has implications in counseling patients with those perioperative adverse events, and really emphasizes that minor adverse events actually don't influence these outcome trajectories. So the complete work is recently out in neurosurgery if you want to have a look. Thanks very much for the opportunity.
And the next speaker is Dorothy Kim.
Prior to orthopedic evaluation, most patients obtain pre-referral imaging in the community. Results will heavily inform clinical decisions around referral and triage. Unfortunately, nearly 30% of AIS patients are late, presenting already as likely surgical candidates at initial visit, and the reliability of community spine radiology is unknown. Our primary study objective was to determine the agreement of Cobb angle readings between community radiology and tertiary care clinicians on the same community-acquired index image. Our second objective was to determine if inaccuracies were associated with late referrals. Agreement was compared with community radiology after index images were independently remeasured by 2 blinded raters, an orthopedic spine specialist and a pediatric radiologist. We then estimated the odds of a late referral given differences in measurement. These Blond-Altman plots show that there was only moderate agreement between community radiology and both tertiary care clinicians. Measurement differences were large, ranging between 6 and 29 degrees, and there was a tendency to underestimate the magnitude of the curve. Ultimately, there was a 3.5-fold odds increase of late AIS presentation when pre-referral imaging was inaccurate. The inaccuracies in community spine radiology do contribute to late presentation, increasing the numbers of avoidable spine surgeries.
Thank you. The next speaker is Jennifer Dermott.
It's not mine. Sorry.
During growth, the brace minimizes risk of progression to surgical range. However, a minority of patients present meeting brace indications and a greater number present late, meaning they're already surgical candidates. We aim to explore socioeconomic status and healthcare utilization that may be associated with this late presentation. Our case control study compared late versus not late AIS patients seen at sick kids over an 8-year period. Their index radiographic data was linked to ICS health databases, focusing on area-level marginalization and use of health services over the previous 5 years. 27% of the cohort were considered late. Of significance, this group was younger and overrepresented in rural areas. The probability of being late increased with area deprivation, with limited or no access to a pediatrician, and with fewer annual health exams. However, any number, even one annual exam, decreased the odds ratio of being late. To conclude, there are disparities in socioeconomic status and how health services are utilized between those that do and do not present late with AIS. There may be a role for education targeted at non-pediatric specialists and for routine screening within our public health care system. Thank you.
Thank you. And the next speaker is Joshua Plenner.
Lumbar spinal stenosis significantly affects one's walking ability, leading to the majority of individuals only meeting 4% of recommended daily levels of physical activity. Self-management strategies are important to deal with these chronic health conditions, but standard self-management with barriers exist with these standard options, such as physical limitations and distance to travel. Digital health interventions can overcome these barriers and provide tailored self-management for these patients. Through intervention mapping, which was through best evidence synthesis and stakeholder consensus meetings, we developed the first mobile app for lumbar spinal stenosis called the Spine Mobility app. The app aims to improve self-management as well as physical activity levels. Key features of the app include daily motivational messaging, reminders and feedback, goal setting, as well as tailored education and exercise schedules. We studied this on 10 individuals in order to assess app usage, compliance, as well as the other key features. Overall, participants described that the app was individualized and tailored to their needs, with only minor changes recommended. Our app has the potential to increase evidence-based treatment for lumbar spinal stenosis, including in rural, urban, and underserviced communities. Next steps include assessing the feasibility of conducting a randomized controlled trial in order to assess to see if the app can increase physical activity levels. Thank you very much.
Thank you. The next speaker is Parthan Amin.
Does the type of surgery, open or MIS, impact the long-term opioid usage? We did the study to answer that question. It's part of the CSON study, which involves 22 centers and a total of 511 patients. 307 were open, 204 MIS, and they were 1 to 2 level interbody fusions. And we found out that there was no significant difference between both groups in terms of opioid utilization. In fact, opioid utilization was impacted by other socio-demographic factors such as the baseline smoking status, the presence of compensation claims, as well as PQH9, which is a score for depression. So these are the factors which impact the long-term opioid use rather than the type of surgery. Thank you.
Thank you. And the next speaker is Peyton Lawrence.
Thank you. Thanks. All right. So just please focus on the bottom line, if you can see it. How many of us in the room have been asked the question, am I going to end up in a wheelchair with my degenerative cervical myelopathy? I'm sure all of us have. And we always say to the patients, no, we'll do your surgery long before that happens. But when they ask you, how long can I wait? What do you tell them? So the last time I was asked that question, I decided to objectively assess our waiting time for our DCM patients. and then substratify the waiting time according to the MGOA. I looked at 107 patients and looked at each MGOA and the wait time for each. I looked at the MGOA after surgery at 3 and 6 months. And essentially, I had this to say. If you can, please limit the wait time for your moderate and severe patients to 4 weeks or less, right? Those were the best performing patients. The mild group is kind of heterogeneous and is a kind of shared responsibility decision. Whether you go front or back is really of no significance. The surgeon should do the surgery that he does best. Thank you.
Thank you. And the next speaker is Tetsu Mimura.
Oh, sorry. Thank you. The current evidence shows that the use of steroids as an option in acute spinal cord injury. But it also shows the importance of identifying the subpopulation of patients with the most favorable risk-benefit ratio. The objective of this study is to clarify the effect of steroids and the impact on complication in cervical SCI, stratified by baseline neurological status. We did pooled analysis with 3 large SCI datasets, and the outcome measure, primary outcomes were upper explanatory motor scores, UEMS, and lower explanatory motor scores, LEMS, at 1 year. To perform subgroup analysis based on baseline injury, patients were grouped by baseline AIS grade, and outcomes by treatment were analyzed using inverse probability treatment weighting. The secondary analysis was in hospital complication. As a result, in AIS grade A, which is complete SCI, the use of steroids resulted in significantly higher weighted LEMS, but no UEMS at 1 year. Notably, steroid has a favorable safety profile with reduced cardiopulmonary and the GIGU complication in cervical SCI cases. Thank you.
The next speaker for repeat performance is Ahmad Essa.
Hi. VT complication are common complication following spinal cord injury. So we wanted to evaluate the timing and trend of VTE prophylaxis and the impact on VTE complication occurrence in the last decade. So we took data from the TQIP from 2013 to 2020. Our main outcomes were time to VTE prophylaxis, VTE complication occurrence, and return to operational room. The study included over 5,000 patients, and as you can see, appreciate in the graphs, the VTE prophylaxis have been going with a decreasing trend, starting with almost 4 days, 10 years ago, reaching up to 3 days in 2020. The same thing we can see also appreciate in terms of VTE complication in a similar trend. There was no difference in terms of unplanned return to OR. Thank you.
Thank you. And the final speaker in this session is Yosef Al-Jaman.
Looking at this X-ray 60-year-old female undergoing a long segment fusion, the main question is it really worth it? Who's going to get better? Who's going to get worse? Our primary aim of this study is to assess the functional outcome for these kind of patients undergoing a long segment fusion, assessing them into 1 year and is it maintained over 5 years. It's a multicentric study, 12 centers around the world, more than 60 years of age of patient, and we had a total of 219 patients. Our results showed we had a significant improvement in their ODI starting at the baseline of 46, and at 2 years it was decreased to 27. It was maintained at 5 years. Looking at the walking part of the ODI, we see a significant improvement in the percentage of patients walking 400 meters or more, starting at the baselines of 25%, and it was increased 2 years to 60%, and it was maintained after 5 years. Summarizing the ODI shifting table, which patients with the lower preoperative function had the lowest chance attaining the highest function at 2 years. And basically, patients with the lowest baseline function showed the greatest improvement, and patients with the highest baseline function maintained their highest level of function. In conclusion, we see a significant improvement for patients undergoing spinal deformity surgery in walking, standing, sitting, and it was maintained at 5 years. Thank you.
Thanks to all the trainees, fantastic elevator pitches. We're right on time, and I think we'll break for coffee, and we'll have discussion over all of the presentations over coffee, and we'll reconvene in 15 minutes. I wonder if we could take our seats again. I don't see the chair of our next session. Have we lost Dr. Lewis? Anybody see Steve? Okay, so our next session is on the enhancement of perioperative outcomes in spine deformity surgery. And the first three talks will be looking at kind of different aspects of this, and then we have a few other talks, some new faculty talks, some talks on AI, and then that'll be kind of concluded by an elevator pitch. So Dr. Lewis perhaps was, okay, yeah, just give him a call. Dr. Lewis maybe was called away on some clinical duties. So I'll actually kind of lead off this session, and I'm going to talk about the prevention, diagnosis, and management of one of the most feared complications that we see in spine surgery, which is an intraoperative spinal cord injury. And it's Professor Hugh in her lecture kind of alluded to some of the risks that we're seeing early on in the evolution of vertebral column resection. So don't have any relevant disclosures. The work that I'll be presenting is part of a focus issue, which presents a number of different guidelines and systematic reviews and care pathways. This was published in the Global Spine Journal. So these are two of the articles from this focus issue that I'll be making reference to. So intraoperative spinal cord injury is a challenging complication, and neuromonitoring has been developed to detect changes. But the challenge has been that there's been a lack of guidelines regarding the definition of an intraoperative spinal cord injury, the incidence, diagnosis, prevention, and management of this. And so we undertook to systematically review the literature, and then this was filtered through a process called the Grades of Recommendation, Assessment, Development, Evaluation methodology. It's the GRADE methodology, which has now been accepted by the Cochrane Commission as a preferred approach to develop guidelines. So the aims were to try to have a definition for intraoperative spinal cord injury, to try to categorize which cases were at higher risk, to try to get a handle on the incidence and risk factors, and then to look at the accuracy of intraoperative neuromonitoring, and then to try to get some consensus over how to utilize this and to develop a care pathway that could potentially be used. So just kind of by way of example, to show one of my own cases. So this is a young 43-year-old man. He's a physician. And he's essentially presenting with early tetraparesis, and he's got horrific cord edema. And if you look on the right, he's got an enhancing intramedullary tumor in the vicinity of the coracospinal tracts. And this is a hemangioblastoma, and this is a very, very challenging case to manage. So how do we optimize a neurological outcome? So I'll kind of go over this quickly. This has now been published, but we undertook a number of systematic reviews and scoping reviews, and these are registered on Prospero, and a quantitative meta-analysis was undertaken, particularly with the intraoperative neuromonitoring. And then we used a GRADE methodology to filter the evidence and to come up with some consensus-based conclusions and care pathways. So just kind of in summary, for those of you that aren't familiar with GRADE, so the traditional way to develop guidelines is that basically if you have a randomized trial, you end up with a high-level recommendation, and then observational studies, lower levels of recommendation. And often you'd see some of the literature where they're basically unable to come up with any recommendations. So that's really not very helpful. And so in GRADE, you take the quality of the evidence based on high-quality systematic reviews, but then you filter this through multidisciplinary a group of individuals to look at the balance between benefits and harms. You actually include people who've lived experience in this process. You look at resource utilization. You come up with recommendations. So the first kind of outcome was a definition of intraoperative spinal cord injury, and this is a new or worsening neurological deficit attributable to spinal cord dysfunction during spine surgery that's diagnosed intraoperatively via a neuromonitoring and or a wake-up test, or immediately post-operatively based on clinical assessment. And, truthfully, there's a lot more that can be done in the literature to try to accurately define this, but the two highest risk types of cases are the one that I showed, which is the resection of an intramedullary spinal cord tumor. It's probably the highest risk type of case in spine surgery, followed by certain types of deformity surgery, particularly higher risk deformity surgery. So then, using a grade approach, there was an attempt to develop a table. And of course, whenever you do this, it's going to be criticized, well, you're not including this, or you're including that, or what do you mean by this or that? This is really just a guideline, I think, to allow physicians to kind of assess patients. But, higher risk cases might include so-called higher risk deformity, so rigid thoracic curve with a high deformity angular ratio, particularly revision congenital deformities. And then, lesions associated with cord compression, in particular intramedullary tumors, and then certain types of fractures, particularly associated with ankylosing spondylitis, and then cervical myelopathy, particular OPLL, which is recognized to be at high risk. So this is a forest plots, and this is an analysis in several 100,000 patients. So this is quite a bit of work that was done by the team, and I want to have a shout out to one of our research fellows, Alvi Mohammed, who led the charge in this. The bottom line is that multimodality electrophysiologic monitoring has a sensitivity of around 91% and a specificity around 95%. So it's not perfect, it's clearly technique dependent, but it's pretty darn good. And it will vary a bit according to disease, pathology, and some of the best literature is actually from the deformity field where this was kind of originally developed, as Serena Hugh kind of outlined. And then there's a whole different set of methodologies used to validate this. But the bottom line is, I think you can kind of take this 91% sensitivity, 95% specificity home. So then the first key question was, well, should we recommend intraoperative neurophysiologic monitoring for patients undergoing spine surgery deemed to be at high risk? You think this would be intuitive. I can tell you, we're already getting uproar and pushback in the literature, and there's going to be editorials, and, are we implying that every single patient should have neuromonitoring? What if it's not available? And so on and so forth, But this is what happens when you start making these recommendations. So here's the first recommendation. We recommend that intraoperative neurophysiologic monitoring be employed for high-risk patients undergoing spine surgery. And the quality of the evidence, even though there's meta-analyses in huge numbers of patients, was felt to be low. And grade is a very stringent process. Why? Because there's no randomized trials and so on. But you can still make a strong recommendation. Why? Because there was felt to be quite a strong signal, and it was really the clinicians really felt that that this needed to be strongly recommended. So this is one of the beauties of grade. You can actually come up with recommendations even when the quality of the evidence may not be as high. So this is adapted from Vitali's a paper. And I want to credit Steve Lewis for actually first drawing my attention to this a few years ago. And it's not perfect, but we have modified. And there are surgical factors, neurophysiologic factors, technical factors, anesthetic systemic factors that you want to kind of consider, intraoperatively. And kind of the summary recommendation here is that it's suggested that patients who are felt to be at high risk for an intraoperative spinal cord injury during spine surgery be proactively identified, so that you identify this, you let the patient know that, that this is a potential issue, that there be a multidisciplinary team discussion, and that you have some kind of a protocol that's established, in advance. And again, the quality of the evidence supporting this is low, and all of this needs to be validated. And so this is kind of the the care pathway that we have suggested, and this is just a template for teams to potentially consider using. So step one is the initial clinical assessment, so identifying the patients that are at high risk. Step two is preoperative planning. This is so important for any kind of a complex surgery. Step three is the surgical and anesthetic planning, having a clear game plan of how to handle the patient. So for example, what are the MAP targets to shoot for? What do you do if there is a change that occurs? What's your protocol going to be? And then the intraoperative management. And here we have essentially kind of modified the approaches suggested by Vitaly. And I think this is going to be in constant evolution. I think Steve Lewis is going to make reference to some of the work that they've been doing as well. And then kind of the post-operative management. How are you going to handle this? The type of imaging that you might use, having a monitored bed, and so on. So just kind of come back to this case. So there was a lot of preoperative discussion that occurred. There was a multidisciplinary management, informed consent. We had multimodality electrophysiology, post-operative advanced nursing, preoperative and intraoperative use of corticosteroids to try to manage some of the AV shunting, tremendous spinal cord edema. So this is kind of at surgery. So on the right, that's a spinal cord, and that blush seen dorsolaterally, that's actually the tumor in the AV shunting. And I've done a myelotomy, and this is actually quite a vascular tumor. And these tumors are very vascular. You can't actually get into the tumor because they bleed like crazy, like an arteriovenous malformation. And here we're monitoring the motor vocal responses from the upper limb. And we did get a reduction from the upper limb response. And we took a pause, we redosed with steroids, made sure the MAPs were okay, then completed the tumor resection in a different area. And ultimately, we were able to achieve a complete a resection of the tumor with a very good neurologic outcome. So the key next steps, I think, in all of this are going to be related to knowledge translation, implementation, kind of test driving this validated care pathway. And there's a lot of potential barriers in terms of the implementation of intraoperative neuromonitoring, as we're aware even in our country. There are many centers where this is quite a challenge. And we also need to have improved neuroprotective strategies when something occurs to mitigate this. So in summary, this is the first evidence-based comprehensive guideline and care pathway for the prevention, diagnosis, and management of intraoperative spinal cord injury. We hope that this will facilitate improved patient management and stimulate groups to test drive this proactively. Thank you.
We'll be open for some questions now for Dr. Failings.
To do this? Is it personnel? Is it the technology? Because these kinds of signals are ones that can be interpreted. And, is there a role for machine learning or other things, or is it about the setup and, how do you scale this kind of technology?
Yeah, you summarize all the key limitations. So it's money, it's technology, it's personnel, and so that's the challenge, right? Who's going to pay for it? Is it justified in all cases, and so on? So fortunately, most spine surgery is quite safe, including most deformity surgery is quite safe. And then in the absence of a care pathway, so I've heard surgeons say, well, I don't even want to know, because then it's just going to freak me out. It's not going to make a difference. But I would say that actually does make a difference, because you can actually change things, the way you manage things, and it's better to know kind of up front. But I think one of the big challenges is going to be, to make the argument that it's cost effective and to have people trained and then to have the equipment in place. And even in our country, there's a lot of places where it's not so available, to be quite honest with you. And this is in a first world high economy country, let alone low and middle income countries. So I think that's going to be one of the biggest challenges. But one of the pushbacks has been that even when people accept the fact that it has a very good accuracy, the pushback has been, well, there's not a care pathway. So this is why this was developed, to actually have a care pathway to say, okay, here's how you can try to diagnose the case, and there are things that can be done to potentially prevent some of this, or if it occurs, to have management strategies in place.
Okay, I'll just do one last question. So, Mike, I think it's very important, and guidelines and guidance for surgeons is really important. We just finished our prospective study on deformity. We had over 500 cases, and the interesting part is that we were very good at preventing spinal cord problems, but we actually weren't very good about nerve root problems. And we had about an 8% incidence of no alerts and patients having nerve root injuries. And we're trying to figure out some of our protocols, perhaps, especially on non-cord level surgery, where it's very frustrating. Everybody's high-fiving in the OR, and then the patient has a drop foot. So, is there any kind of guidance that we could give for us for and improvements in some of the nerve root monitoring that we do?
Yeah, and I mean, you're very aware of this, and you've led some important work through the AO to look at the interpretation of the intraoperative neuromonitoring. It changes. So the techniques that we have include free-running EMG, the use of evoked nerve stimulation, motor evoked potentials. And unfortunately, free-running EMG varies. If you have changes that occur, you need to pay attention to it, but it's not that sensitive or specific for that matter. And I think what we're doing increasingly, even in kind of lumbar surgery, where in the past we wouldn't have used motor evoked responses, we're now using motor evoked responses, and I think that's probably one of the best techniques to use. And then I think the other challenge then is, okay, you have a change that occurs, what do you do about it, right? And I think this is where we also need more research in terms of, are there some drugs that we can use to try to attenuate this, like, riluzole and these types of, these types of drugs.
Can I just quickly ask, those findings, was that EMG only, or was that?
We did EMG, we did SSEP, and we did motor evoke. 8%.
Yeah, but MEPs are probably the most accurate, I would say, yeah.
The problem is a lot of it is hip flexors, for example, and we couldn't monitor them. And so a lot of, we try to do adductor for hip flexor and some other things, but definitely, and then some of the places didn't have enough channels to check enough legs at the same time as well. So we're trying to coordinate how many, the protocols that are relevant so that if you only have 3 channels in your legs, you're gonna have to pick which muscle group you're gonna have. SSEP in particular, we only had 1 channel in the majority of the cases. EMG was terrible in our series.
I would say that EMG monitoring alone, unfortunately, is not that accurate. Like if it occurs, for sure. But I think that some of the technical limitations that we've seen, like with MEP monitoring, relates to like technical. So I think maybe if you have a case that you're concerned about having more channels available to be able to place electrodes in some of the key myotomes. I think it's just that sometimes the surgeons may not be aware that the technologists are actually only monitoring a limited selection of muscles, mainly to look at cord issues. Yeah, exactly. So I think maybe having some discussion around which muscles, to look at.
Okay, thanks a lot. Okay, thanks, and I want to welcome, it's a real honor to have Serena here, and I know a lot of you have made a lot about that she's a female, but she is damn good. She's a great surgeon, and she's a great researcher and a great leader, and she's on merit, no matter what sex she is, she's awesome, and really an honor for us to have her here, so. Thanks a lot. So I'm trying to look at maybe a little bit going forward on Dr. Failing's study that we looked at how to do some prospective studies, and we'll go over some of the things. And the good thing about spinal deformity surgery is a lot of complications happen, and despite our best efforts, we do our best to manage them as best as we can. And the rates vary for the procedures. Some are higher, some are lower, but how you manage them, how you recognize them, deal with them, and learn from them are really some of the key features that we do. And this is kind of the basics of our research. There are patient factors too, and there's certain things that just maybe are more modifiable than others. And then we have lots of failures. We can fail at the junctions, we can have pseudarthrosis, we can have infection, neurologic deficits, malalignment. And then some are technical. We fuse too short, we fuse too long, we don't fuse at all. We're malaligned and managing with different implants. So there are different issues that we have to deal with deformity. And it really makes, when you have such a high issues to manage, it makes it really ripe for good research. So we have a lot of unknowns. Who should we be operating on? What is the ideal sagittal alignment? Why do we have such a high complication rate? Can we do better? There's also high stakes in terms of the spinal cord and nerve roots, and really it's a ripe field for us to study. So we do a lot of little studies. We said, we do these cases, and we have this nice 13-year-old with a big deformity. Everybody's excited after surgery, and 3 days after, her leg hurts, and you can see she has a chance fracture through the bottom level that we fixed. And so, we put a hook in it, and we're excited that'll work, and 3 days later, that's pulled out. So we ended up doing some temporary fixation down to her pelvis so that we didn't have to fuse more levels, but we were able to salvage her levels. And we have published on her case about 3 years later how we were able to salvage her without fusing her longer through temporary distal fixation. And we learned from other things in anterior compression. We can see our sagittal alignment from old techniques where you anterior compression, you create such a great deal of kyphosis that we were able to manage. And then we looked at this lady and we said, oh my God, she has a right-sided implant system. And then we looked, and you can see how the screws are kind of nicely embedded in her liver, and we say, how are we supposed to deal with this in terms of getting it out? And so we kind of get creative. We're back surgeons, so we go from the back, and we're able to do some techniques to take this out without having to biopsy her liver. And we wrote about that. So these are different things that we can do on a small scale, and then we're pretty happy. She's very happy, and we're able to write about how to get a screw out from the back, which is very nice. But these are nice on a small scale, but can we do things on a bigger scale that have a greater impact on the way we do business? So the key is to really know what are the important questions that you have to ask. There should be a decent amount of controversy in these things to make it more interesting. And you need a lot of investigators who are willing to collaborate with you to help you find the answer. And then you also need a good organization that'll help you, to support you, to help get things done. So we looked at spinal deformity, and what are the dreaded things is really spinal cord injury, and we don't want any of that. And it's potentially preventable with some good neuromonitoring, intraoperative neuromonitoring, giving you real-time feedback so that you can respond appropriately. And then by responding appropriately, you can do the right things and help reverse this. But the problem is that there's a lot of controversy when an alert happens. What do you do? And so the key is to say, there's a lot of unknown answers. So let's identify an important problem that needs an answer. And so we looked at it and we said, we need help on how to manage these intraoperative alerts. How do we correct safely? What monitors should I use? What is the blood pressure I should be looking at? What do I do if I have a loss of SSEP? What if I have a loss of MEP? What if I lose both? And what do I need to do to get the signal back? And so how do I get from someone with a big deformity and you lose the signal to be able to salvage the signal back so that you can actually get your rods in and get a correction and everybody's happy at the end? So there's been a lot of work with checklists. I've been involved with Mike Vitale. We met in Salt Lake City, in Utah on the ski hills, and we all sat and met for a little bit, skied for a little bit, and came out with this checklist. And then we decided that the checklist was too simple. Perhaps we may make it much more complicated. And so 8 years later, we looked at trying to make an incredibly complicated checklist. But the problem with these checklists is that there's no protocol still with them, and there's no established association between the intraoperative events and the maneuvers you need to make. And then all these changes are lumped together. So if it's SSEP or unilateral MEP or bilateral MEP, it shouldn't really have the same checklist. And so some of these things are all lumped together and really don't differentiate from some of the issues that we need to deal with. So how do we get to having a good idea with a big problem and get there as well? First, let's do a pilot study. And at Sick Kids, we have probably one of the best neuromonitoring that we could find for kids. Kids are a lot easier to neuromonitor than adults because their signals are strong, they have great spinal cords, and you don't have a lot of nerve root problems. You're really dealing with mainly spinal cord problems. And so we looked at 97 cases that we did there, and we divided them up into traumatic events and perfusion events. So if you took, for example, a kerosene on your release for the apex and you, by mistake, had a little bit of a nudge on the spinal cord, well, you're going to probably get a unilateral change, in which we did. And we had 16 of those. Whereas if you just put your rod in and stretch the spinal cord so badly, perhaps you're going to get a bilateral MEP alert, and that would be more perfusion-based problem. And so we looked at it, and really we could see this pattern of unilateral losses from a traumatic event, because we had the events that occurred, and then perfusion events from either too much traction or just putting our rods in. So we had a really good correlation of that. And then obviously, if you can know what the problem is, then it's fine. And it makes it a lot easier to manage. So if you just put your rod in and you have a perfusion problem, well, you take your rod out and take a breather and say, how can I improve my perfusion? Well, I probably need a little bit more blood. I probably need a little bit more blood pressure. And then you can fill the oxygen tank and then put your rod back in and then have a happy solution. And then when for a unilateral, for a traumatic event, we looked at it and said, you know what? There's two types of traumatic events. There's one that there's traumatic event with ongoing compression on the spinal cord, and then, for example, with this kerosene, we took the kerosene out, so there's no ongoing compression anymore. And so those will obviously be very different in terms of the way you manage it. And so by taking some of this, a pilot study, we then looked and said, you know what, let's get a bunch of people together and see if we can collaborate and get a nice study going. And so fortunately, I've been involved with the AO Knowledge Forum for Deformity. I'm the current chair of that. We had a big discussion and we said, you know what, this is a really good project for us as leaders for a global way to make an impact for spinal deformity surgeons. And then we went and begged for money, and which was fun. So AO Spine gave us a big chunk of money for it, and we also got grants from SRS and the British Scoliosis Society, who were interested in participating in our thing. And then we had to create a clinical investigative plan. So we worked pretty hard on that. And with AO, you have to only put about 47 pages together for your clinical investigative plan, looking at getting the collaborators, getting a primary objective, secondary objectives, and look at the outcome measures and the secondary outcome measures you're trying to achieve through this. And then we spent a lot of time creating a standardized form. So if you're going to do neuromonitoring studies in different centers, everybody's got to be collecting the same data. And so we spent a ton of time working on these forms, looking at demographics, some of the male, female, the basic demographics, the type of deformity we're looking at, how big the TURB. We, instead of seeing everybody's x-rays, we had them measure them all by themselves. And then we looked at, what are you doing in the surgery? Well, are you doing anterior, are you doing posterior? Are you doing interbodies? Are you going to do lateral interbodies or posterior interbodies? And are you going to do osteotomies? And then at what levels and what types? So all this data we collected. And then if you did have, are you going to be using traction during the surgery? And then are you measuring your blood during the surgery? And then what kind of correction did you get? So can we correlate correction and the monitoring? And then if you did have an alert during surgery, well, we wanted to know what you did and what you did at the time. So what was exactly happening at the time of this alert? So how long was it from your time of surgery? what was the blood pressure at the time, what was the MAP at the time, what was the hemoglobin at the time, and then what was the change? Was it EMG, was it SSEP, was it MEP, was it left leg, right leg? Which muscle groups were actually affected? And what were the events that you did prior? Did you just put your rod in? Did you do exposure? Did you put a screw in? Did you just do an osteotomy? What part of the osteotomy did you do? And then we're looking at different other features in terms of, did you just put your rod in, or we're using traction? So, and then once you had this alert, what did you actually do? And so you just had to tick off what you did in response. Did you elevate the blood pressure? Did you give blood? Was it a technical problem you had to adjust? Did you take your rod out? So we had all this thing. And then we correlated the timing of the recovery over time to see if they got any recovery. And then we did a neurologic assessment. So the neurologic assessment had to be done pre-op and post-op. And so we looked at both kind of on the ASIA scale, looking at both root problems and cord problems to see if we can isolate any syndromes. And once we finished with these forms, then the next thing we did was we had to recruit sites. So we had an open call from AO. We had 450 applications, and we picked 22 centers. Unfortunately, 19 were able to enroll patients, which we did over a 3-year period. And then we had about a 15. We tried to pick cases that would have a high rate of neurologic change, and this is our distribution from the different centers that we used. And then once we got all this data, we had to look at it, and it's really confusing data to look at. We had about half were children and half adults. We looked at the overall, we ended up with what we decided as cord level problems versus non-cord level problems. And you can see the alerts that we had. The majority had a single alert during the surgery, but we did have 20 patients that had multiple alerts during the surgery. And what we did in response and things like that. So we've created these subcommittees to help look at the data, to help us analyze and understand what things are. And then we're trying to answer the questions that we wanted to do. So what are the frequency of the alerts? How do we characterize the type and cause of alerts? Can we differentiate the perfusion and traumatic injuries? And then isolate the different type of alerts in terms of SSEP, MEPs, combined alerts, bilateral, unilateral, and then whether the alerts the responses you did in response were very good. And then even can we identify a threshold value for which we should be checking? And really, we want to help identify deficiencies in our current protocols. We want to create algorithms for the various types of alerts, guidelines to how to manage these alerts, and how to create these updated, perhaps, protocols that people should be using for their deformity surgeries. So the important thing is to ask questions that need answers, design protocols that will answer your question, involve knowledgeable, engaged colleagues, use centers that have required infrastructure, hire an experienced CRL to help you with getting things organized, engage participants throughout the process, and the highest quality studies will be best done with a really good collaboration. So thanks a lot. Okay, we'll take if there's any questions or.
So where are you in getting the centers involved?
We're done with all the data. We've collected 555 cases. We've had 15% changes. It's really interesting. For example, if you lost 100% of the signal during surgery, we had a 45% chance of neurologic injury. If you lost 75 to 100, we had a 22% chance of a neurologic injury. And if you lost 50% or more, it was down to 15%. And 8% had no alerts. So it was actually kind of really good data, and we're trying to really knock down. We're looking at our bilateral alerts separately, our unilateral alerts. The multiple alerts are a little more complicated, so we're going to look at those separately, and I think that's important for a surgeon. If you have if you just have a single alert and then it recovers and then you have another alert, what does it mean and how to manage it? So it's a lot easier with cause and effect if you have a single alert all the way through. When you have multiple alerts, we're trying to figure out which one is the most important. But we're really working. We have a team of about 40 surgeons really keen. The whole statistical team in Switzerland are working on it. And I hope we're going to have some really good answers and a lot of good studies coming up in the next year. So. Nice.
Steve?
Yeah.
Were you able to differentiate cases which were monitored through a machine those who were monitored with personnel around, and those who were monitored with neurologists being away in another room, not participating in the surgery?
I think we didn't ask that question originally, and it wasn't, it was a really good, that would have been a really good put on our demographic table. I didn't think about that. But the centers would know, so there's only 19 of them to come back to, so I think it's a very good point, and we should look at that. It's a really good, thank you for bringing that up.
It's a really terrific work, and thank you, Steve. It's often very difficult to obviously talk about these sort of issues, and these sort of adverse events can certainly profoundly affect quality of life and patient outcomes. I guess my question relates, a lot of it is sort of expertise, experience, and clearly you've got a group of 40 surgeons and their related teams that do this on a regular basis, but there's some variability on patients, and also depending on the type of scenarios, a lot of the debriefs sort of afterwards, you need to sort of integrate what the electrophysiologist started seeing, what the surgeons has done, and an assistant sort of put it all together. And so are you able to comment a little bit about that process in terms of how that sort of integrated to be reported? Obviously you're getting that, sort of combined input in terms of those data forms?
Yeah, so the forms will have the data as kind of that I showed, but the communication that happens during surgery, we don't pick up on 100% in the forms, and I guess it's very different. And like Reinhard says, are you using neurologists? Are you using techs? Is the surgeon, who's running this thing? And I can tell you when the anesthesiologist puts a bit of gas in there and your signals go down, it makes it very, very difficult to manage. But there's a real importance in communication throughout the surgery as you're bringing up. And I think that's it's something that is really important. There's nothing worse than bad monitoring, and a lot of bad monitoring could be related to anesthesia or some other things, but there's nothing more confusing when you can't correlate what you've done in surgery. It's really nice that, if you take a Kerrison and you hit the cord and you have a change, that's good. But when you feel you've done nothing and you've lost it, then it really, it's really frustrating. And then you have to kind of look at different things. But the communication between everybody is really, really important, as you say.
And I guess with the forms, is there a section the anesthesiologist fills in as well relating to?
Well, we had the tech did most of the form, so we would just ask the anesthesiologist, and then they would, the tech would fill out that part with the anesthesiologist at the same time. Yeah.
Thank you.
Okay, so we'll move on to the next talk. Unfortunately, Dr. Nielsen's stuck in the operating room, and I'll be giving his talk, but I can't do it as well as him. I'm sorry, but I'll do my best. We'll put up Dr. Nielsen's talk. I can't. So Chris Nielsen's one of our more junior partners that has been with us for about 6 years. He's really an incredible surgeon, a really great colleague to work with, and working hard with us. He's an associate member of our AO team, and he's done very good work in our group for research. He even won the Louis Vialli Award for his contributions, and also worked with Fatima and just won the research award for our associates for their work on sagittal alignment. So we look forward to collaborating. They're going to be collaborating with Mike Kelly's group in San Diego for that too. So I'll do my best to present his work today. And really, as the title says, we're trying to really, how can we make spinal deformity surgery safer? And really, we look at it as two things. Is there, patients may have issues, but some of them are modifiable and some of them are not modifiable. And then can you modify them enough to make the surgery as risk-free as possible? And so there's a big group from the ISSG, led by Doug Burton, for this group, looking at some of the modifiable things. And they did a structured literature review to try to determine what sort of modifiable things can we identify in patients before surgery. And they looked at a few things which was important. The preoperative hemoglobin, patients that are anemic have a lot of different issues. Their bone density, which is something that we can help. The albumin was a reflection of their protein. And smoking was obviously, we have a very high pseudarthrosis rate with smokers that increased our complication rate in adults. On the second part of it, they were kind of looking at to see, is there things that we can do on our other things that were, or some of the other factors, and they looked at, and they saw that the mental health disorders, frailty, vitamin D deficiency, and diabetes were all major impacts on having a higher complication rate in our deformity surgeries. We worked with Naresh Babu won one of these associate awards for us and worked on a project that we had to help with get going with Marinus and trying to really look at spinal deformity patients on a more holistic level as opposed to looking at just their x-rays. And then one of the big factors was their general health. And looking at these premorbid states to see which are going to be modifiable or not was the first part to really define what sort of patients we're dealing with, and kind of goes over a lot of the stuff that was done in the ISSG thing, and looking at frailty, the ASA grade, osteoporosis, BMI, smoking, and diabetes as major factors that have major impacts on our outcome for our patients. So in this article with SIG's group, they looked at a more recent one looking at the preoperative medical assessments of these patients. And again, the same kind of things come up. The frailty is a big problem. And then that was good evidence on that. And then some lower evidence for diabetes, smoking, and bone density. And then some intermediate risk factors were mental health, social support, and opioids. So very, very similar findings has been held. But when you look at it, is what are modifiable and what are not modifiable, and what can you change, and what can you not change. And we kind of look at those things together. You know, the hemoglobin is easy to change. The bone density may or may not be, it may need a lot of work. Vitamin D deficiency is a problem in Canada. Diabetes and lifestyle are things that you have to work on to improve our things. Some of the things are less modifiable, like the frailty, the mental health. No matter how hard you work on it, it's very difficult. And the BMI, again, you know, if someone's living on Coke and chips, they're going to live on Coke and chips, and it's hard to change a lot of that things. So if we look at some of the things that we looked at, the increased severity of anemia was interesting, was twofold increase in complication rate if you were anemic with surgery. So these are really important, and they used a threshold of 135 for hemoglobin, which is you know, a lot more common for our females who have periods to have hemoglobins less than that for a lot of the spinal deformity surgeries we look at. Zishan Sardin is also part of our AO group with, in New York, looked at osteoporosis, which is a very important part, and looking at some of the factors. And, you know, these are modifiable things that we can do now, and there's been a lot of more aggressive treatments. We know that the anabolic agents have been a lot more effective than the other ones that we've been using because they have less effect on the bone turnover and a better results for our fusion rate. So we're looking at these best practice guidelines and working on osteoporosis. Obviously, with a very high screw density for our patients, these are very dependent on bone quality. So we looked at the biphosphonates, really not a good thing. These are the first line agents that a lot of people use, but they limit bone turnover, which is a really important portion of what we need to do for spinal fusions and things like that. So these anabolic agents have been a really much better option for us to stay away from and improve our fusion rates for these patients. In terms of outcomes, we've identified depression has been a major cause. This was Justin's work from 2006 with a very high prevalence rate of depression for these patients with a very negative outcome for these. And then you can see that in terms of the depression, the operative patients were a lot more depressed than the non-operative, which is something that's been shown in a couple articles. And perhaps the pain and the chronic pain that people live with may be a major factor leading to higher rates of depression. You know, in our group, we looked at as well, so you can see the EQ5D from our outcome. These are patients over 60 undergoing deformity surgery, and interestingly, their their depression actually improved after surgery, so that the chronic pain was improved because we had a big improvement in brain for these patients, and their anxiety and depression improved as well after surgery. So it's a very important component that the chronic pain does drive the depression a lot, and some of it may improve with what you're going to be doing with surgery. In terms of smoking, we know smoking has a higher incidence, and Alex with the ISSG group came out with a really nice paper looking at complications in deformity surgery, and smoking was an important risk factor with almost 2.5 time risk factor of having adverse reactions. The other thing is the frailty. There's been a lot of work also with the ISSG group and some other groups looking at the frailty, and the frailty of the patients. Frail patients don't do as well with surgery, and they have a higher complication rate, higher worse outcomes, and things that may or may not be modifiable with some of these things, but it's something we identify before surgery and look at some of these factors that hopefully can get resolved partially at least. And then the last one of the main things is diabetes. It's in our institution, Raj Ramprasad's been doing a lot of work for us and looking at the A1C for our pre-op patients and seeing that as a modifiable factor that'll improve, decrease our infection rate and improve our outcomes for these patients, not only deformity, but for most of our other patients as well. So when we look at that, we really want to identify modifiable problems, both medical, lifestyle, and which we can change, and hopefully impacting these, identifying them and working hard to identify them and work on them preoperatively, either with multidisciplinary committees will help us come through with better outcomes for our patients. Thanks. Any comments or questions on that? Hey, Carlo.
Sarcopenia, it wasn't mentioned. Is that like a surrogate with the frailty, or is there any comment?
Yeah, it's part of the frailty. Yeah, so the sarcopenia is a big part of the frailty indexes that we use. But I guess you have a lot of experience getting the patients up and moving. Do you want to comment on your opinion?
Yeah, so we can't measure the psoas muscle, of course, but we use calf. We measure the calf. Is another good surrogate because we know frailty is a particular of premature death. And so we try to rehabilitate these patients, getting them walk on their toes on the washroom, walk on heels back, doing things they do every day anyway to try to incorporate exercise in their daily activities to get them more compliant to exercise and rehabilitation.
So just if people don't know, Carlos, probably one of the premier spinal stenosis non-operative treater in our group, and has made a major impact on a lot of our patients, so thank you. Michael?
Yeah, thanks, Stephen, and thanks also to Chris.
Yeah.
So I was actually going to direct the question to Serena Hugh, and this kind of begs the whole concept of ERAS, enhanced recovery after surgery. And I'd just be interested in a nutshell, are you doing any sort of ERAS protocols for any of your spine patients, spine deformity patients?
We have had an ERS protocol in place for all of our spine patients for a number of years. It's hard to quantify the effects because it's their historical data versus current. It does seem to facilitate the patient's recovery. But I'm also a big fan of optimizing patients preoperatively and pretty much everything that you've agreed to. The hard part is quantifying how much you need to optimize, like, so activity and sarcopenia, how much do you need to get them to walk before they've now out of the frail group and, are more fit and ready to go to surgery, for example. I mean, A1C is easy, osteoporosis takes a while, like you mentioned, but some of the measures are a little bit harder to quantify as far as what the target should be.
Yeah, thanks. Right.
As a therapist who deals with this after the fact, have you looked at the recovery of the motor when you get the root and you get weakness? Is there a recovery rate that we and the patient can expect, or do we have an awareness of that?
I think it's a great question, and it is very variable, and you have some that recover right away, and there's some that don't recover. As surgeons, we look, when someone has a deficit, we look for, is there ongoing compression? And so they'll get imaging after surgery, see if there's if there's a screw in the wrong spot or a piece of disc or a hematoma or something to cause it. In the absence of that and riding it out, the ones who recover early recover well. And we often will do some nerve studies at the 3-month mark to get a better idea if there's high potential or low potential for particular patients. But when we see a deficit, we just can we reverse the compression if there is any? A damaged nerve is a damaged nerve, and you just have to ride her out. But if there's something pressing on it, that's something that may potentially be reversible that we'll try to address. Okay, thanks. Is Jatan here? Okay, so we have Jatan, who's new faculty at Sunnybrook, a graduate of the Toronto program, and an all-star in the making. We look forward to your talk on surgical timing for spinal cord injuries. What is the evidence now?
Thanks, Dr. Lewis, and welcome, Dr. Hugh, to Toronto. So this talk is a bit of a departure from the discussion of spinal deformity and intraoperative spinal cord injury, looking at kind of, traumatic spinal cord injury and the contemporary evidence surrounding timing of surgery. So this piece of paper originates from ancient Egypt, 17th century BC, and it has what we think is the first ever description of spinal cord injury. And if you translate it, in essence, it describes spinal cord injury, and then it kind of says an ailment not to be treated. And the reason I put this up here is I think it really speaks to the fact that, from the beginning of time, in essence, how notoriously difficult this condition has been to treat. And if we consider where the road has brought us kind of all of these centuries and millennia later, there really isn't a whole lot that we're able to offer, unfortunately, in the acute and hyperacute setting. So blood pressure control, MAP augmentation, steroids, depending on how you want to interpret the literature, and then surgical decompression and early surgical decompression. There is a strong biological rationale here, right, in terms of primary injury and secondary injury, looking at the pathophysiology of spinal cord injury. And the rationale is that perhaps if we intervene earlier and decompress the spinal cord, that we can mitigate the degree of secondary injury that's going on from compression and ischemia to the spinal cord and restore perfusion to that ischemic penumbra. So this is borne out in animal studies. So we basically know that if you induce a spinal cord injury in an animal, that the outcomes are better if you surgically decompress the animal, and that the effect of that improvement is kind of related to how quickly you're able to decompress them. In humans, we first have to ask, how do we define early versus late? And much of the literature would support a 24-hour threshold, both partly biologically, but partly also just practical limitations of how soon can we get to these patients. And this was from now about 6 or 7 years ago, but things have changed a little bit, but the idea was that the role of decompression kind of within 24 hours was still very much controversial, and definitive evidence of benefit was lacking. So this is a study that was done as part of a guidelines development process in 2017, trying to develop guidelines for surgical decompression in the setting of spinal cord injury. They looked at a 24-hour threshold and identified 5 studies in the literature. And unfortunately, partly because of how things were measured and reported and conducted in these various studies, it wasn't really possible to pool the results in any type of meta-analysis. And so the guideline that emanated from this process stated that we suggest early surgery be offered as an option for adult acute spinal cord injury regardless of level. And this was based on low-quality evidence with a weak recommendation. And so all of that is just to say that there's a critical need for higher quality evidence in this arena. And so we kind of undertook a study And given the limitations of the literature, what we wanted to do is make sure we had a large sample size so that we could derive precise estimates of the treatment effect. We wanted long-term follow-up, kind of beyond 6 months to about a year. We wanted to be able to look at subgroups, and then we wanted uniform outcome measures to be able to pool these results in some type of meta-analysis. And so this is a paper that we published now about 3 years ago. And this is from a harmonization of 4 large data sets in North America, looking at the NACT and SCI registry, the STASCA study, which was the largest study prospective that had been conducted to the date, the SIGEN trial, and then the NASCUS-3 study. And we looked at all patients who had a traumatic spinal cord injury, Asia grade A to D, who underwent surgical decompression. So we dichotomized patients into early and late groups based on a 24-hour threshold, and then we measured their outcomes at 1 year. The primary outcome was change in total motor score, and then secondary outcomes were change in their sensory scores and Asia grade. So we first did one-stage meta-analyses where we used a hierarchical mixed effects regression model with an intercept to account for the fact that these were coming from different studies. And then we adjusted for their baseline severity of injury, the age, mechanism of injury, their baseline Asia grade, the neurological level, and then whether or not they got steroids. And we summarized the effect size by mean difference for total motor score and then the odds ratio for Asia grade. We then did some secondary analyses. So we did a 2-stage meta-analysis, which is kind of what we traditionally think of when we think of a meta-analysis with patients being derived from different papers or different sources. So basically you derive a treatment effect for each study individually and then pool them together. And then finally we did some subgroup analyses. And then finally, as a further analysis, we wanted to look at time as a continuous variable to see, even within that 24-hour window, does earlier surgery basically provide a greater benefit? And so we used a generalized estimating equation, a linear regression for the outcome of change in total motor score, and then we modeled time by a restricted cubic spline, and we adjusted for the same covariates that I mentioned earlier. So we ended up with over 1,500 patients. 1,000 of those about underwent late surgery, and 528 underwent early surgery within 24 hours. These are their kind of baseline demographics. In general, the early surgery group had more severe injuries and tended to have a preponderance of cervical injuries in particular. So on both 1-stage and 2-stage meta-analyses, we see that for all of the outcomes that we looked at, that early surgery within 24 hours was associated with greater improvements in outcome at 1 year for total motor score, light touch score, pinprick score, and a more favorable change in Asia grade as well. And this is looking at the Asia grade, so we see a shift in favor of early surgery in the distribution of Asia grades at 1 year. On subgroup analyses, there was no heterogeneity or treatment in the treatment effect, meaning basically regardless of what category you belong to, it appeared that early surgery did provide benefit. And then this is looking at when we modeled time as a continuous variable. You see that within the first 24 to 36 hours, earlier surgery does result in superior recovery at 1 year, but then after about 36 hours, things level off. And this kind of lends credence to the idea of ultra-early surgery, meaning we can shoot for a 24-hour threshold, but it appears even within that 24 hours, sooner is better. And so to conclude from this, we would say that surgical decompression within 24 hours does improve sensory motor recovery in SCI. It appears that that first 24 to 36 hour window is a critical time during which earlier decompression may augment neurological outcomes, and that thereafter the benefit of timeliness may be lost, probably because of some degree of irreversible tissue injury. Some of the strengths of this study, so this is the largest to date, kind of overcame a lot of the limitations of previous studies. We had long-term outcomes. We used individual patient data. And we used a number of different analytic techniques and derived kind of the same conclusion regardless of what technique we used. Some of the limitations are that this is obviously still not, a randomized study, and so there is still the possibility of some residual confounding and selection bias. These were multiple sources of data that basically spanned 3 decades of treatment, and so there's inherently heterogeneity in that, and that we didn't have some type of functional outcome or quality of life metric. And so more recently, this year, the guidelines were updated, kind of another systematic review was done, and the study I kind of just described and several other studies were kind of included in that, and on that basis, the strength of the recommendation was upgraded to strong based on moderate quality evidence that early surgery be offered as an option for SCI regardless of level. The second piece to this guideline was looking at the question of ultra-early surgery, and ultimately there just wasn't enough data to provide a clear recommendation in that regard. But ultimately, this idea of ultra-early surgery is kind of where the literature is moving. I think it's probably kind of the next iteration, if you will. There have been a number of papers that have been published looking at a 12-hour window or an 8-hour window, and it does appear that the outcomes are even better if you can get to these patients earlier. And so I'll come back to kind of that description and the fact that we've now gone from this being an ailment not to be treated to one that we recognize should be treated rather expeditiously. Thanks for your attention. I'll take any questions that you might have.
It's great to see you up there as faculty. So it's a wonderful presentation. Okay, great. So we have this. So where are the barriers, and why is there some pushback occurring, you think, from some quarters of the community?
Yeah. So I think one of the critical barriers is that if we look at patients with a spinal cord injury, we know that only about 50% of them are actually, is it feasible to actually get to them early within that 24-hour threshold? And part of the problem, lies at the systems level of, these patients get transferred to an intermediate center and then away transferred to kind of the site of definitive care. And by the time all of that is coordinated, that window of opportunity, that ship has kind of already sailed. So I think part of it is trying to get these patients more urgently to the site of definitive care. And then even at that hospital, there's often workup and things that need to be done in the way of, an MRI and so forth. So developing protocols that can kind of, quickly get them through the appropriate workup. And, there has been some discussion and thought surrounding whether, this should be declared some type of code situation so that scanners are on hold and so forth, and these protocols are well developed. And I think some of the resistance, if you will, to this probably stems from just bias, historical precedent that, many years ago, these patients were kind of kept on bed rest in a halo and so forth. And it's just kind of overcoming that stigma, if you will.
Yeah. So I guess systems issues, but the other challenge that I also see, though, is the aging demographic, right? And patients presenting to us with complex medical issues. And even if they get to you on time, it may not be wise medically, right, to operate early. Yeah.
Yeah, I mean, I just had 2 on call there on Fixaban, so which makes it a little more complicated.
Anybody over here in the country after 10 years.
Yeah. So, Justin, thanks. I have a question from the audience, from Amir Asef. Did you control for factors like needing vasopressors or if they needed steroids?
Steroids was controlled for. The blood pressure augmentation was not, so we didn't have data on whether or not that was done, but presumably in most of these patients, just the way kind of clinical care for spinal cord injury was dictated at the time, we presume that they would have gotten MAP augmentation.
Two comments. First of all, I think we're really lucky to have you as a colleague at Sunnybrook, and so thank you very much for all the work you've done, and it's been great seeing where you're going. The question I had for this data, which to follow up to Dr. Fahling's question, is I still have some people that are pushing back with the concept of early decompression for people with central cords. And I know that the last AO paper kind of took everybody together. When you look at your data, did you separate central cords, or were they all part of the same continuum of injury? And is the benefit as robust for central cord decompression as it is for what we consider a classic spinal cord injury?
Yeah. So, as part of this analysis, we didn't kind of divide the data that way. But stemming from this data, I have done some further work specifically looking at the central cord population. And even within that subset, it does look like early surgery, within 24 hours does improve their recovery. That being said, inherently in that population, there's a lot of challenges, some of the medical issues in particular, but there is definitely a signal there. And I think the data and guidelines for central cord are also kind of moving in that direction.
So Chen, what's your experience around the city in terms of timing for spinal cord injuries acute?
I think it's probably evolved over time. I would say, as a trainee, there was certainly a lot of heterogeneity in the way these patients were treated. And I think as time has gone on, for the most part, there's greater uniformity now. The question always comes up, even locally at Sunnybrook, is if they come in the middle of the night, do you do it right away? Do you wait till the morning? And I think in general, these are not simple operations. They're quite involved. It requires a whole, experienced team. So most of the time we do try to do these during daytime hours if we can.
50 years ago, we started answering this question in the lab with good, solid animal data. Is there any of that going on today? Like, do you get support from basic science studies of early decompression that would help the clinical answers?
Yeah, I think for sure that's kind of where all of this started, as in terms of in animal models, it's quite clear that the earlier, the better. And some of that work is still being done, and for sure kind of lends leverage to the clinical side of things.
Okay, well, thanks a lot.
Thank you.
I'd like to invite Michael for AI-enabled medical imaging analysis for the spine.
Great. Yeah, thanks for giving me the chance to talk about my research. I'm a scientist at Sunnybrook, and I'm going to talk about my research program. Okay, so in my research, I use medical imaging, and so medical imaging is usually used qualitatively, and my work is to try to make more of it, to make quantitative predictions or to improve visualization using medical imaging for a number of spine indications. I'm going to talk about a few of those in this talk. Okay, so my work's related to the field of computer vision, which has seen really a lot of development in the consumer space, particularly advances in deep learning that really have made these computer vision models work much, much better for segmentation or object detection or classification. And it's really their ability to leverage these large data sets that are more and more available. So this is my research vision: to improve understanding of spine disease, provide personalized treatment solutions using computer vision or medical image analysis. The first indication I'm going to talk about is spinal metastases. So spinal metastases are a common complication from many tumor types, and they cause mechanical instability in the spine and can lead to neurological complications. One of the primary treatments, a common treatment for them is stereotactic body radiotherapy. It's this patient-specific application of high-dose focal radiotherapy It's effective for the control of tumor and pain, but there's a significant incidence of vertebral compression fracture following the procedure. I'm showing an example of this where a patient was ablated with T4, T5 T5 levels, and then there's subsequent imaging showing a kyphotic deformity caused by a vertebral compression fracture. The way that these patients are assessed clinically uses the Spinal Instability Neoplastic Score, or SINS, and it's a score that was established by the Spine Oncology Study Group in 2010, and it assesses 4 variables. It uses the location, whether the patient has mechanical pain, the type of bone lesion, whether it's a lytic or a sclerotic or mixed lesion, the spinal alignment, whether there's deformity, kyphotic or scoliosis or subluxation, if there's already existing vertebral body collapse, and if there's posterolateral involvement. And so this SIN score is summed, and then patients are categorized as unstable, potentially unstable, or stable or unstable, potentially unstable. And it's a semi-quantitative, and there's the literature is mixed on its on its relationship to vertebral fracture risk. And right, so my work in this particular project is to look at building a more sensitive and specific tool to predict vertebral stability. We want to use standard of care imaging so this can fit into clinical workflow. A lot of my work uses standard of care imaging. We want it to be automated and easy to use. And to address this need, we've developed an automated tool for the prediction of vertebral stability using deep learning. Specifically, what I'm showing here is a multitask ResNet that we refer to as VertDetect. And this allows us to automate the SINS assessment and also do some quantitative assessment of similar biomarkers in an automated fashion. So here's a closer look at the specific elements that are output from the automated SINS. First, the pipeline is trained to segment and identify each vertebrae, and the system reports or calculates the 4 image-based SINS elements. I'll talk about each of them now. So the first SINS element is bone lesion. We have a histogram-based method that we can use to segment and classify the regions of the vertebral body that are lytic or plastic, and we've shown that it agrees well with manual assessments. We also look at automating the assessment of spinal alignment, again, by leveraging the the segmentation of the vertebrae and using detection of vertebral body centroids and M-plate locations that are detected from the segmentations. We use an ensemble method to calculate coronal and sagittal angles with the accuracy shown here when compared to manual assessments. And then the next element is vertebral body collapse. So again, by using the adjacent vertebrae, the segmentations of the spine, we can estimate the target vertebrae, so the vertebrae that's being considered for treatment. We can estimate the amount that it's collapsed by looking at the adjacent vertebral body volumes, and then using a local spine fit to then estimate the amount that it's collapsed. And we've shown that using this sort of approach to estimate vertebral body collapse can actually be useful for understanding patients that go on to need stabilization by observing the amount that the body has collapsed pre and post procedure. The final SINS element that we're going to look at is posterolateral involvement. This is involvement of the posterior or lateral elements with the tumor involvement. We've developed a CT-based method here that uses features that we learn from our VertDetect model, and then uses some additional convolutional layers to then classify the presence of tumor involvement when comparing to manual identification. And we've shown that it does agree, our method with a kappa of 0.41 agrees better than residents do with each other, but it's slightly worse than how well expert staff agree in doing this task, which they have a kappa of 0.48. And so this is CT, and we also are looking at, current work, we're looking at building a method that uses a similar approach for MR-based assessments. So we've tried to combine these features and use a random forest classifier to predict who's going to have fracture post the procedure and show that we were about 3 times as sensitive when we used these features in our preliminary analysis. However, we still have ongoing work to apply this to the entire data set that we've built. I'd like to draw attention to, let's see, one of our trainees is talking about looking at other factors that are outside of these outside of these imaging-based features, looking at other clinical factors. Dr. Burgess has a pitch talk, I think. And so finally, we have a system for quantitative and automated SINS assessment that can we use to improve factor risk prediction and help us understand stability and I guess the idea is how to manage these patients better, improve patient outcomes. So it allows personalized treatments. As a result of this work, we've created the largest spine SBRT data set that includes both patient data and imaging data. And we're focusing on developing this into a clinical decision support tool. And we'll want to influence the next generation of guidelines on how to manage these patients. So I'm going to switch gears a little bit now and talk about some different biomarkers that are focused on osteosarcopenia. It's something a number of people have talked about. I guess osteoporosis and sarcopenia. And so it's a newly described syndrome that incorporates both osteopenia and sarcopenia. It's been popularized since 2015. It's prevalent in older individuals, and it's useful for predicting lots of outcomes for many clinical procedures. And osteosarcopenia is co-occurrence of, let's see. So sarcopenia and osteoporosis occur commonly in prostate cancer patients. They interact with disease progression as well as many of the treatments that are prescribed for advanced prostate cancer influence both muscle and bone health. And so prostate cancer patients, particularly that are treated with androgen deprivation therapy, have a significant risk of developing sarcopenia, and also they have bone disease. And so even patients that are ultimately cured or don't end up dying from prostate cancer still have a large impact on their muscle and bone health and their quality of life. So this project, we're looking to improve predictions and better understand the interaction of this syndrome with the disease. So we are looking at, so we developed a so we have a study. It's a retrospective study that looks at quantifying osteosarcopenia progression in advanced prostate cancer patients that are treated with systemic therapy. And then we're looking at essentially all their clinical imaging. And so these patients get serial imaging, which allows us to monitor their osteosarcopenia progression. They get serial imaging to monitor their metastatic disease. And then we're looking at this against their clinical data, their electronic medical records as well. Okay, so of the 960 patients that we identified, 916 of them ended up having imaging studies that were sufficient to be included in our study. So this is the biomarker extraction pipeline. The input to the pipeline is standard of care, the 3D CD reconstructions, sagittal, coronal, and axial, that are commonly used to, diagnose and monitor these patients. And using a similar approach to what I described in the spinal mets work, we're then quantifying their musculoskeletal health by looking at the psoas muscle, both the volume and the density in these abdominal CTs and lumbar CTs, and also looking at the density of the bone in the lumbar spine. Today, we've conducted a pilot study where we looked at how well did our pipeline work on 42 of our patients, and this turned out to be 475 of the CT scans, and we quantified the same biomarkers that we planned for the whole study. We looked at how well our methods agreed with manual assessments, both in 3D and in 2D. So in 3D, we looked at how well did our segmentations agree with manual contouring, and in 2D, we looked at common ways that sarcopenia is assessed using 2D cross-sectional areas, and how well our 3D measures agreed with them. So we didn't expect perfect agreement when assessing 2D versus 3D, but we are focused on 3D biomarkers because we're trying to understand this temporal progression and wanting to have more sensitivity to temporal changes. So the pilot study results, we did see evidence of sarcopenia development in most of the subjects. And then in bone mineral density, we actually saw two different groups, one that had stable or decreased bone density, and then the other that had a really large change, really large increase in bone density. And we think these patients had sclerotic lesions involved in those lumbar vertebrae. That is common for this particular type of cancer. So the impact, ultimately, we're trying to describe the natural progression of osteosarcopenia in prostate cancer patients over time, evaluate the impact of treatments and the disease on musculoskeletal health, and identify specific patient and malignancy risk factors that can influence the development of osteosarcopenia, ultimately to better guide therapy and make predictions based on routine standard of care imaging. Okay, so the next thing I'm going to talk about is again using the same kind of tools, our computer vision tools, but more for building patient-specific spine surgery simulations in virtual reality. And so this is motivated by the complexity of spine surgery that necessitates preoperative planning, careful preoperative planning that some of the other, presenters spoke about. And it's extensive. The training required is extensive and costly. And virtual simulation can allow, some experiential learning experiences and improve procedural understanding and lead to faster competency. And we're focused on patient-specific simulations because we think that this can, integrate better into how surgical residency works now and give a simulation that's relevant to the case that is being considered right then by the surgical resident. So we again use our similar AI-enabled patient-specific tools to do CT-based segmentation of the musculoskeletal structures, and then use MRI to segment the neural elements, then fuse these using some automated registration, bringing down the time to create these models from days to weeks to a few minutes. And these are some pictures of our current patient-specific virtual reality simulator. Let's see. Okay, so we tested, so in some retrospective analysis, so looking at retrospective cases, we did test a version of our simulator with fellows and residents at Sunnybrook and showed that they did learn, particularly for the junior trainees, there was a bigger benefit. They did learn something about the procedure and the anatomy, and there was an overwhelmingly positive review. So to sum up, I've looked at some AI-enabled medical image analysis for the spine. We've developed some novel technology for spine medical image analysis. We looked at prediction of fracture risk using standard of care imaging, allowing minimally invasive monitoring of musculoskeletal health, as well as applications to image-guided therapy and surgical education. So I'd like to thank all the collaborators. I've been involved with the spine program for a while. I've become a scientist or an assistant professor in the spine program now. So I'm technically new faculty, but it feels like I've been here for years. So I really appreciate all the support that all of these people, lots of them in the spine program here, and the trainees as well as the funding.
Great work. Mike, are you guys doing it prospectively if a patient walks in the emerged, or do they call you up and say, can you put this through on your computer and let me know what to do?
So for the, which part?
Let's say a MET comes in.
Oh, a MET comes in. So I guess we're not doing that yet. We're still grinding through the retrospective analysis to verify how much better are we at predicting. But that is that's the next study, the prospective, where they come in with a MET. We then tell them, we think they're going to fracture, we don't think they're going to fracture. Yeah. Or probably they intervene and we make our prediction, we see what happens, but yeah.
And can you predict if they've got radiation, if they're going to fracture first?
Well, that's the idea that the idea is the need we focused on is, you need to make a decision about whether to give them radiation or not, is how we've approached it. So they're coming in, the docs think they need radiation, how likely is it they're going to end up fracturing? So that, because they might consider doing something before radiation or giving them less radiation is kind of what the radiation oncologists have told us. So do they need to get a surgical consult? Do they need pre-procedure stabilization before they end up fracturing. And so they're trying to make that decision better, is really the idea. So that is the idea, like, can we stabilize them before radiation, or can we give them less radiation so they have less likely to fracture?
And then how are your trainees responding to your, do you find?
The trainees?
Yeah, for your simulations.
So certainly they're enthusiastic to try out the virtual reality simulations. I think it is about, one of the challenges is getting it, so I think any sort of friction, the trainees don't have a lot of time. I think residents seem very busy. So we want to make it as smooth as possible. So we have worked a lot on making it easier to get the simulation working, having someone to support them. So I think it is about that. Certainly when they get using it, I think they do enjoy using it and they do find value in it. But I think it is coming over that, and virtual reality is we're still solving some of the technical problems in virtual reality. It's still, there are still challenges in translation. I think just with the VR technology, it's come so much further than it had, even a few years ago. Like the quality and how quickly you can get it to run and how great the simulations are. But I still think there's this, getting the hardware to work, it still requires a lot of our engineering support.
And how do they correlate it with the navigation they're going to use, for example? Because is your technique more for freehand use, or is it going to be for incorporating it with their navigation guidance, if that's what they're going to be using?
So right now it's freehand use. Sorry. Right now it's freehand use is what we have, but we are looking at integrating simulated navigation into it that would give a similar visualization so that you can, marry what you would see from the nav with what you would see freehand.
Great talk. Sorry, I realize this position is invisible to the modern, but just wanted to ask, so the image analysis to predict the SINS components, have you kind of looked at predicting or trying to kind of move away from the SINS and like a less supervised way of predicting stability, like as an outcome, rather than necessarily SINS components, just out of curiosity?
Yeah, so we are looking at doing direct fracture risk prediction from the imaging. So we kind of took the approach that we wanted to, so I guess with deep learning, you need a lot of data, right? So we were a little bit concerned when we started this project, would we have enough data to just throw in the image and then output a prediction on fracture risk? So we built a model and tried to get it to learn things that are a similar task, so that we can then transfer that knowledge to do direct fracture risk prediction. And so, one of our staff is working on doing direct fracture risk prediction now. But also there's the question of translation. How easy is that to interpret? How generalizable will it be? So when you do direct fracture risk prediction, you need a lot more data in order for it to generalize well. Whereas there's a lot of information that's already, the fact that we use these SINS components, like the expert knowledge that went into saying that this was important, and then the literature saying that that is actually important for fracture risk, we're kind of piggybacking on that information being created, and then like rescaling its use with like a classifier that uses it as in a reduced form. So I think there's value in doing both, and we're going to explore that direct fracture risk prediction. But we also took the elements because it's interpretable, and we likely need less data to do it.
Thanks very much.
Okay. Thanks so much. Thanks a lot for our speakers and for the good timing. So the good news for our extra time is that the elevator pitch, we're going to maybe give them an extra few seconds so they don't have to rush so much. Unfortunately, Dr. Crawford can't be with us today, so I think our next step, we'll go for the elevator pitch. And I'll let you guys breathe for an extra 30 seconds, okay? So for each of you to talk. So first one would be Laura Burgess. Machine learning tool for prediction of vertebral compression fracture following stereotactic body radiation therapy.
Okay, so building off what Michael just talked about. Okay, so I'm one of the radiation oncology fellows at Odette. And as we know, stereotactic radiotherapy to the spine achieves impressive rates of local control, as well as pain response with a fairly low risk of adverse effect. That being said, the most common adverse effect after spine SBRT is vertebral compression fracture, or VCF. And this occurs in an incidence of about 10%, and this can cause pain, instability, deformity, or even spinal cord compression. And we can see that here in a patient treated with spine SBRT. She went on to develop significant kyphotic deformity requiring decompression and fusion. And there's been growing interest in the development of patient-specific tools that are capable of predicting those at a high risk of developing VCF, with the hope that this could allow us to improve our clinical decision-making, better counsel patients, and also consider prophylactic interventions, particularly attractive in the era of minimally invasive surgery and percutaneous procedures. And so we developed a machine learning tool that predicts for VCF following spine SBRT. It uses clinical dosimetric and radiographic data that's contained in a large patient database, the largest in the literature, of patients treated with spine SBRT at Odette. And it outperforms our current clinical standard of SINs that we were just talking about, with a higher sensitivity, specificity, accuracy, and precision. That's it. Thanks.
On disparities in surgical timing following traumatic complete spinal cord injury, role of insurance coverage and race.
Thank you. As Dr. Badihawa mentioned in his last presentation, the surgical timing in spinal cord injury is critical, important. Therefore, in this study, we wanted to evaluate the impact of insurance and race on time to spine, on time to spine surgery in spinal cord injury patient. To do so, we have conducted a multi-center retrospective study using data from TQIP from 2010 to 2020. The main outcomes were time to surgery, hospital length of stay, and ICU length of stay. For each of our outcomes, we have constructed an adjusted model, adjusted again for patient injury and hospital level. In the first analysis, we can see that there have been increase in time to surgery in terms of public and uninsured patient, as well as non-white patients. In the second analysis, we wanted to evaluate the adherence to a 24-hour threshold surgery, and we found out again that public insurance and non-white race were associated with a reduced compliance to 24 hours threshold. Thank you.
Okay, we have Kumar.
Thank you very much. Yeah. So, becoming a spine surgeon, it needs either training in orthopedic surgery or neurosurgery. Unlike the residency training, which is well structured, most of these spine training fellowship programs are not standardized or not even accredited. So our institution tried to address this issue by following the Canadian guidelines as well as registering the cases on surgical TROS application. With this, the objective of my study is tracking fellows' surgical experience through procedural confidence and competency by reporting the self-evaluated tool, that TROS application. And the methods were from all the cases registered from 2015 to 2023. And the results were almost 7,961 cases were registered by 39 fellows over the period of 9 years by 39 fellows. Mean cases reported by per fellow was 178, and the results were very impressive. And here in the results section, we can see the cases, the confidence, those cases which is performed by fellows like a degenerative cases, the confidence is less as compared to the infective cases, which are even fewer in number, like 216. So the conclusion of my study, three conclusions from my studies. The standardized case log is very important for fellows training and the perceptives. Secondly, it's very helpful for Canadian spine guidelines, and the Royal College developed the guidelines. And the third is very important for the preceptors also and the mentors, how they are developing the fellows curriculum. Thank you.
Maria Pia? Maria? Oh, sorry, yeah, sorry, I said Abbas, I'm sorry.
So just a quick note that I'm up here on behalf of Azad Abbas. So scoliosis has a large impact on the health-related quality of life for patients. But surgical management for scoliosis is common. However, there's limited consensus on the optimal preoperative and intraoperative strategies to maximize health-related quality of life outcomes for patients. So the goal of this feasibility study was to try to build machine learning models using preoperative and intraoperative factors to try to predict health-related quality of life outcomes postoperatively. So we accessed a longitudinal database, and we were able to build these models using various preoperative and intraoperative variables as the inputs, and then the outputs were various health-related quality of life outcomes such as pain, mental health, among others. And these measures were at 2 years post-op. And then in assessing the accuracy, we compared it to mean estimates when we found that our models were able to accurately predict health-related quality of life outcomes at 2 years post-op. And so I think the main takeaway from this research so far is that there's a potential to implement these machine learning models to try to help with guiding operative planning, and also providing a bit more guidance to unexpected outcomes of surgical management to patients. Thank you.
Maria? And talk on 7B.
Good morning. So the goal of our study was to study a single surgeon machine vision technology, as known as 7D, learning curve based on the navigation time per screw in a pediatric neuromuscular population. For that, we did a retrospective study assessing clinical and radiographic records of all patients that underwent posterior spinal fusion and instrumentation with pedicle screws placed with the 7D navigation. We assessed demographic data, scoliosis etiology, radiographic data, and some surgical outcomes. So a total of 32 patients underwent surgery between July 2020 and June 2023, with a mean age of 14, BMI of 17, mainly females with cerebral palsy and C-curves with apex lumbar. 88% of the surgeries was trainees assisted. 25 of the 20 inserted screws and 15 of the 16 navigated vertebrae were navigated with a mean operative time of 585 and navigation time of 147. Our mean, 26 of these patients had a pelvic fixation, and 16 of these 26 patients, the S2I screws were navigated that allowed the operative time 30 minutes less. Our mean navigation time per screw was 5 minutes and 56 seconds, and is diminishing during the time. I had not that.
Okay, Adrian on spine stereotactic body radiation.
Thank you. How do we move to?
Yeah.
Okay, hi. Right, so our study is about the risk of SBRT in the elderly patient. After SBRT, there's this 10 to 15% chance of past fingervertebral compressive fracture. And there's this concern that this risk may be high in the elderly where the bone mineral density may be poorer. So we look into our institutional database and review all the treatment outcome in elderly patients treated with SBRT and see if age can be a predictor of the risk of SBRT. We found that about the age of 86,
the risk of VCF is significantly increased. The 2-year risk increased from 11% to 30% using the age of 86 as a cutoff. This remains significant on multivariate analysis. And reassuringly, below the age of 86, the risk is pretty similar among the age group from 70 to 75, 75 to 80, and 80 to 85. And so we think that SPRT should be used with caution in patient age 86 or above. Thank you.
We have Soichiro. Assessing LDX-induced restoration of inhibitory signaling after traumatic spinal cord injury.
Hello. Following SCI, as you know, various pathophysiological factors hinder the neurological improvement. Apart from them, the imbalance of chloride ion in neurons after spinal cord injury decrease inhibitory signals. As a result, hyperexcitation cause neurological impairment. So this project aims to assess the effect of LDX, which is one of the loop diuretics. Loop diuretics in restoring inhibitory signals after SCI. We use a click compression cervical SCI model and perform LDX IP injection. The preliminary data suggests the dose-depending effect of LDX, and 6 mg per kg of LDX shows a significant improvement compared to the vehicle. Thank you so much.
Dr. Dantis talking about neuromonitoring.
Good morning. So this is some of the data from Dr. Lewis's research. This was a multi-center prospective study, and the purpose of the study was to describe the events that occur prior to intraoperative neuromonitoring alerts in deformity surgeries. More than 500 patients were included. Overall, they had a 14% rate of intraoperative changes. And the surgeries were divided into cord-level surgeries and non-cord-level surgeries. So for cord-level surgeries, osteotomies were the most frequent cause of unilateral MEP changes, whereas rod placement and curve correction was the most frequent cause of bilateral MEP alerts. And for non-cord level surgeries, osteotomies were the most frequently associated with both unilateral and bilateral MEP changes. So in summary, osteotomy release and rod placement and correction of the curve were the most frequently events associated with MEP changes. So those are the critical steps that require meticulous handling to prevent neurologic injury. Thank you.
We got Dr. Lawrence discussing on circumferential cervical spine fixation in a single center.
Thank you. So 360 cervical fixations are a difficult but necessary operation, especially when done as a single stage. They can be quite anxiety-provoking and even cause premature aging of surgeons. So I decided to ask myself, is it better to split this up as a staged procedure or do it all at one go? Professor Feelings is a one-go surgeon, Dr. Masikat is the opposite. So I examined 50 elderly patients, mainly ankylosing spondylitis, chalk stick fractures, and bilac facet fractures. And I looked at some outcome metrics. Half of the cases were done as single stage and the other half were done as multi-stage. And I noticed a commonality The only in-hospital mortalities were the staged procedures. Those procedures were associated with prolonged ICU time and overall length of stay. So again, focus on the background and try to excuse my dyslexic typographical error there. And if you can do a circumferential fixation as a one go, it's probably better. If you cannot do it for whatever reason, and the patient resembles our friend there on the top right-hand corner, perhaps consider abandoning the second stage and using just one stage for your fixation. Thank you.
Have Parthan discussing the impact of concurrent deformity on patient-reported outcomes.
So the goal of our study was to see if limited surgery, which is limited fusion or decompression, which is 1 to 3 levels, has an impact depending on if there is a deformity or not. What we did was essentially compare the patient-reported outcomes at baseline, 3 months and 12 months, for these patients with concurrent deformity and without concurrent deformities. The method was through the CSON registry. We collected data on 438 patients, 311 with no deformity and 127 with deformity, and the results were that the deformity patients did worse perioperatively, so all the perioperative measures were worse, but when adjusted for baseline differences in demographics, the patient-reported outcomes at 3 and 12 months in most measures were the same. So patients with lumbar spinal stenosis or spondy with concurrent deformities have no significant differences with those with deformities for limited fusion surgeries.
Ahmed's going to talk to us about complete cord injuries.
So this paper is actually a success story. In this paper, we wanted to evaluate the real-world clinical practice in terms of surgical timing following complete cervical cord injury. So in order to do so, we conducted a multi-center retrospective cord study. We used data from TQWeb from 2010 to 2020. The study included over 6,000 patients. As we can see, that median time to surgery from 2010 to 2020 have been consistently decreasing. And the factors that were associated with increasing the time to surgery were penetrating injury, comorbidities, other systemic injuries, and lower Glasgow Coma scale. And the decreasing time to surgery actually was associated with younger age. Thank you.
Sidney Brocky will be our last speaker on roles of different factors in cervical myelopathy.
Okay, so my work is presenting the role of microglial CX3-CR1 chemokine signaling following decompression in a mouse model of degenerative myelopathy. And so to study this, we used a pancellular CX3-CR1 receptor knockout mouse strain, as well as a conditional ablation mouse strain, which allowed us to specifically ablate microglia expressing the CX3-CR1 receptor. And here we found that after this ablation, we were still actually able to maintain a residual CX3-CR1 negative microglial population, which is denoted by the small green pie slices in the bottom 2 pies there. And what we found about this distinct CX3-CR1 negative microglial population is that they demonstrate reduced vascular association following surgery. And so you can see that they are not found alongside these green-stained astrocytes at vessel walls the same way that they are in wild-type animals. And this might actually be protective in reducing acute vascular leakage post-surgery. Further, we found that they also retained a reduced ability to phagocytose, and this was coupled by the fact that they actually had an impaired ability to engulf synapses. And by reducing their synaptic engulfment, they were actually probably able to contribute to the enhanced neuronal survival that was present up to 5 weeks post-surgery in these Crelox animals. And so by taking this comparative approach where we compared the functional readouts of deleting just a receptor versus ablating this distinct cell population, we can gain insights as to functionally beneficial microglial populations that may be harnessed to improve endogenous recovery following surgery.
Okay, thanks for the speakers, and thanks for everybody staying on time. It looks like everybody has a little more time to eat lunch, so we won't have to do it so fast. And then Michael.
Yeah, so I think we're about half an hour ahead of schedule. So in speaking with Albert, we thought maybe we would reconvene at 1 o'clock, which gives everybody about 40 minutes for lunch. And I see that our speakers for the afternoon session are here. So we'll see you in about 40 minutes at 1 o'clock.
Gradually get started, and I hope everyone's enjoyed lunch. We're going to segue to the next session of our program, which focuses on our invited trainee presentations as well as our best abstract and oral presentations. And so the first session on our invited research trainees are basically individuals that are in our training program that have obviously made a value sort of contribution in terms of their endeavors and have already presented and sort of received prestigious awards and recognitions for their work at some of our other meetings in neurosurgery, orthopedics, and within the Faculty of Medicine and Department of Surgery. So it gives me great pleasure to introduce the first speaker, Dr. Carlo Pedro, who will be speaking on enabling novel paradigms, an empirical multidimensional approach in clinical spine research. Pedro's been a clinical research fellow at the Toronto Western Hospital as part of the U of T spine program. Graduated from the University of Philippines, received some additional training in Montreal in neurotrauma and critical care. He's received a variety of prestigious research and clinical awards, and is currently completing a PhD in the Fings Laboratory, and will be coming on staff, back on staff and faculty at the University of Toronto and Toronto Western Hospital. So thank you.
Thank you, Dr. Yee, for that introduction. And thank you, Dr. Hugh, for joining us in the SpineFEST today. So this morning we've been talking about big data sets, registries, and large data in spine surgery. And I think my talk will be helpful for us to understand the ways by which we can deal with these large data in spine surgery with the hope of comprehensively representing the outcomes as well as the clinical profiles of our patients. So I have no relevant disclosures for this talk. It might interest you to know that spine surgery is one of the largest contributors of data in the realm of healthcare data analytics. In one of these articles that I encountered, it's estimated that a spine fellow who's fresh from training and has an average of 35 years of career will generate around 40,000 data points in a span of 35 years. And in one of these articles, it's estimated that around just using the electronic health record by 2023, there's estimated to have 154 billion data from spine surgery, from the field of spine surgery alone. This is a dashboard in one of the clinics in spine surgery, and the US has now been shifting towards more of a PRO-based quality metrics where they measure a lot of patient reported outcomes. And these dashboards are rich repositories of data that can be actually used for doing research. But EHR is only one of the sources of data. We have biobanks, we have mobile data, we have genetic data, and this can all be used and harnessed to improve our understanding of the disease physiology and pathology. This is an article showing the national registries we have in spine surgery. And I was in the meeting in CSRS last week, and it's very noticeable that many of the researches are based from big data, big spine registries. And here you can see that the researches has been increasing for the past decades, and these are mostly coming from big spine data registries. And here in Canada, we have one from the Canadian Spine Outcome Research Network. These data are important because we can actually leverage them and feed them into more complex analytical techniques within the realms of machine learning and artificial intelligence. And we've actually been using this in our clinical spine laboratory to help us understand better selection of our patients, and more importantly, identify unique patient phenotypes. So we have our own share of big data in our clinical spine laboratory. And these are basically the studies that have been spearheaded by Dr. Failings, both in DCM and traumatic SCI. We know that both of these categories are now considered important causes of disability. Degenerative cervical myelopathy is the most common non-traumatic cause of spinal cord dysfunction, and we know that traumatic SCI continues to be a problem. And now there's a shift towards a fall predominant mechanisms. So as we stand, we currently have 2,600 patients in spinal cord injury database and around 1,048 patients in our TCM data. And one of the revelations that we've been discovering is that we're really dealing with a highly heterogeneous patient population. So in DCM, for example, we deal with young, old, male, female, but more importantly, they come in with different sort of clinical profiles. Some have predominant lower and upper extremity dysfunction, but some also have predominant neck pain. And this is also the same in SCI. So we have patients across the Asia grade, but we also have to deal with frail, non-frail, or depressed and non-depressed patients. And this discovery has been validated by external studies showing that DCM patients actually have multiple problems. And pain is an important recovery priority now, but this is not reflected in the most commonly used scale, which is the MGOA. So in our laboratory, we have been exploring ways by which we can analyze this highly heterogeneous data. And in general, we can divide this into a variable-centered approach and a person-centered approach. So variable-centered approach is the classic statistics that we're used to do in our researches, but I think a more powerful analytic technique is a person-centered approach where we take each of these individual data and present their relationship from each other, and through this way, we're able to discover unique patient phenotypes. So in order to do this, we have a non-parametric as well as a parametric method, which I will be showing to you. So this is an example of a variable-centered approach. This was published from our group early this year. It's a study about frailty in DCM patients. So we say that this is a variable-centered approach because we started with a knowledge of their cluster. So we clustered patients based on their frailty scores, and we used conventional statistics to do regression analysis and find that frailty is associated with their outcomes. But I think a more powerful tool is a clustering technique. So this is an example from the COVID-19 study where the authors combined 3 different laboratory results in order to identify 5 unique patient phenotypes, which is differentiated by these colors. And so we use the same technique using the large database that we have in our laboratory, and I'll show you the results that we got. So I've been talking about clusters. In medical research, cluster refers to a group of objects that share similarities. So most of the techniques assume no prior knowledge, and this has been important in disease phenotyping. So this is another figure showing that these techniques are very flexible. You can use clinical data, you can use biomarker data, or use genomic data in order to understand disease pathophysiology. So the goal is simple. You start with this unstructured data. You identify similarities between these clusters, and at the end of the procedure, you should be confident in saying that, yes, we have identified a cluster of patients with different properties. And to do this, we have different methods, K-means, hierarchical clustering, fuzzy C-means, and latent class analysis, which I will be demonstrating here. So we use these clustering techniques in our DCM data. So we started with 1,047 patients. They all underwent surgery. And at the end, we have classified them into success or failure based on the improvement of their symptoms. And what this technique enables us to do is to go back and look at the factors based on the clusters, which we can link with their outcome scores and outcome scales. So we use symptom profile as the clustering method, and we use both K-means and latent profile. So these are the 5 symptom scales that we clustered together, and you see how disorganized they are without the clustering. And with clustering technique, we can now see that we can identify 4, 3, or 2 unique groups of patients based on their 5 symptom scales. At 5 clusters, you start to have overlap, and so we think that 5 clusters is not the best solution. Fortunately, there's a more objective way by using an elbow method to identify the best or optimal number of clusters. We also use a latent profile analysis in order for us to generate statistics by which we can base this optimal number of clusters. And so these are the newly identified phenotypes of DCM patients. And we have identified severe multimodal impairment, minimal impairment, motor dominant impairment, and a pain dominant impairment. And hopefully this will be published soon, has been accepted in one of the Lancet papers. And so the implication of this is that we're able to incorporate what is important for patients, such as neck pain, for example. And we see that if we just use the MJOA, we will be able to just lump the phenotypes 2, 3, 4 as mild DCM and only the phenotype 1 as separate based on their MJOA, which we know is not true based on their outcomes. Another technique that we've been using in our lab is trajectory modeling or growth modeling. And this is basically taking the concept of clustering, but now in multiple time points. And you see this is a very powerful technique, because if we just use mean based on this data, we see that we lose a lot of information. By the use of trajectory modeling, we're able to identify 3 groups based on this technique. So Dr. Badiwala has used this to identify different trajectories based on upper extremity motor score. And one of our team members have used also this technique to identify different trajectory modeling based on neck pain. So in conclusion, this clustering methods is a very powerful analytical technique in dealing and approaching large clinical data in spine surgery. We have used this actually to concurrently explore a way of interpreting multiple clinical endpoints called a global statistical test. And the hope is that these techniques will be able to help us develop a person-centered approach rather than a one-size-fits-all method. So I want to acknowledge Dr. Failings, Mohamed Ali Alvia, as well as the collaborators from Johns Hopkins for this work. Thank you very much.
Some time for questions. Yeah. It's really terrific work, and I think a lot of what we do as clinicians and what we're taught is is a sort of pattern recognition, and I think the sort of approach where you're looking to sort of personalize the heterogeneity of these presentations and the phenotypes that you sort of encounter. Certainly in DCM, I struggle with those patients that they present and they've got clear sort of myopathic signs, but they may be minimally symptomatic, especially from a neck pain perspective, right? And the counseling and decision analysis for surgery, particularly those that may have mild myelopathy versus those with moderate and severe, are a little bit different. So I guess in terms of the phenotypes of presentations, what about the severity as well? Are you able to make comments on that based on some of the
So this clustering method allows us to actually identify groups based on the degree of scores. So we have, if you look at the table in this study, these phenotypes differ in terms of the scores based on NDI, MJOA, motor and sensory. Some are high, some are low, and it's just a combination of these scores that taken together, and that's how we identify the different clusters. So in each of these clusters, they are characterized by different degree of severity in terms of these 5 symptom scales. And we're able to go back and look at their outcomes, and we found that actually using these outcome scales, we are also able to identify different degree of improvement in their, say, MJOA difference at 1 year or 6 months. So we're able to incorporate that severity in the clustering technique.
Great presentation, Carlo, and thank you for presenting what is a very complex process in actually one of the clearest ways I've seen. So I appreciate that from a clinician's perspective. So one of the things is correlation of phenotypes with other data sets. So have you looked at is this correlating in any way, shape, or form with imaging phenotypes, or then you get into molecular endotypes, so it gets really messy.
Yeah.
And it continues to get messy. So the more data we have, the less we seem to know in certain things.
Yeah.
So this is a general comment, but I'm sure you're doing progressive work. But specific to what you have done to date, we know that better phenotyping can augment our ability to predict. Because we can have 3 patients that phenotypically almost look the same, but their outcomes are completely different, or trajectories, et cetera. And our ability to accurately predict outcome at an individual level tends to still be poor. We have AUCs of 0.7, things like that. Has this technique allowed you to try to boost that predictive ability, or is that future work?
Yeah, that's the next step that we're exploring, Dr. Rampersad. And as to your first point, certainly this technique can be expanded to include all the variables that we think are important. And I think this gives us an opportunity as a society, for example, to determine which are important for us as well as our patients. Imaging, though, is a bit challenging because we know that some patients would come in with severe stenosis, but they don't have any symptoms. And the same thing as the other way around, we have patients who have severe manifestation, but if you look at their imaging, they're very mild compression. So I think once we have a better grasp of this sort of uncertainties in terms of imaging, and once we can convert this to numerical values, because these clustering techniques are now sort of limited to only numerical data, continuous data. Even the categorical yes, no, with or without, we cannot cluster as of yet based from these techniques. We need numerical continuous data in order to do these clustering techniques. So once we have that method to transform this imaging into continuous variables, then surely we can use these clustering techniques for sure.
Congrats, excellent work, thank you.
Thank you.
Selena?
Thanks so much. That was really interesting. In my experience, limited, I've always struggled with using this parametric models in clinical data. So we have these, like these numerical models, but they sort of bottom out when you hit 0. So you end up with these non-normal distributions. And the k-means clustering, I think it's great. I love it, but it's really reliant on sort of like a normal distribution. Did you struggle with that kind of data handling issue?
Yeah, thanks for that question. And that's the reason why we combined this with the latent profile analysis, and we just didn't base it from k-means because we know these limitations will come. Even the k-means has a certain sort of bias from the researcher, because in the method of doing the k-means, you actually initiate the number of clusters that you like, right? So you can just basically use how many clusters, but in our research, we complemented with this latent profile analysis where we're able to compute AIC, BIC, p-values, and using this technique, we're able to identify that the optimal cluster is actually also 4, and the k-means is also 4. So sort of they complement each other, and we have more confidence that this is the true number of clusters.
Thank you.
Thank you.
Okay, so our next presentation will be given by Dr. Ali Mohadamju. He's a neurosurgery resident at the University of Toronto training program and is currently completing his PhD under Dr. Failings. He'll be presenting on spinal cord injury prediction models with application to clinical trials. Thanks so much.
So thanks, Dr. Yi, for the introduction. And so again, I'm Ali. It's an honor to be here today to talk about clinical prediction models in spinal cord injury. So I have no relevant disclosures. I first want to acknowledge Dr. Failings, who's been my supervisor and mentor throughout the years, and also Dr. Alvey, who's a research fellow at the Failings Lab, whose work I'll be referencing here as well. So in terms of the outlines for the talk, this is a very general overview of clinical prediction models in spinal cord injury. So I'll first talk about the importance of clinical prediction models, and then I'll go over some of the older models, and then I'll kind of walk through a stepwise approach on how we create clinical prediction models. And throughout this process, I'll highlight some of the models that we've worked on. And then at the end, I'll kind of close with how we can apply this to clinical trial design. So this audience needs no introduction to spinal cord injury. We know that it has a huge global significance and a significant local burden, with almost 4,500 new cases diagnosed yearly in Canada, and each one of these cases has a significant lifetime impact on patients and the healthcare system. And we also know, and we've heard earlier today, that the epidemiology of spinal cord injury is changing. We're getting more elderly patients, and these patients have completely different trajectories and pathology when compared to younger, more acute trauma patients. And because of this kind of changing landscape, it's very important to revisit our previous understanding of spinal cord injury and the natural history of spinal cord injury. So that's one of the main importance of looking at prediction models of spinal cord injury. But the second kind of area is that it allows us to better understand emerging therapies. Because right now, spinal cord injury is a very heterogeneous population with different trajectories, and the effect of an intervention or a therapy can be lost if you don't have a homogeneous population to look at outcomes in. And lastly, prediction models kind of help with decision-making and counseling of patients and their families. So what are the current models that are available? And to answer this question, we did a systematic review of over 7,600 papers, and we broke things down, including we broke it down to current predictors of outcomes. As you can see that there are a lot of predictors that have been identified in the literature. The majority of these predictors have to do with the patient's physical examination, specifically the ASIA grade, and also patient-specific factors such as age. And I want to kind of highlight that treatment is the least cited predictor for outcomes, and this is something that we can work on. In terms of the type of models, the majority of the models are just logistic regressions, but now more and more we're seeing in the literature some of these advanced models that, for example, Carla was referencing, but the majority of the models that are out there are logistic regression models. So the systematic from this, the conclusion from the systematic review is that we definitely need to kind of create new models with newer techniques and bigger data sets. So there is a need for novel approaches, and to kind of, then I'll walk you guys through the steps required to kind of come up with a new model. So the basics are you need data, you need predictors, you need to pick a model, and then you need to pick an outcome measure to study. So in terms of the data that our lab is using is kind of outlined below, and we have overall 3,300 patients. And this is coming from a combination of the NASCAS 2 and 3 clinical trials, the SIGEN clinical trial, the NACTIN data registry, the STASCUS trial, and recently we've added data from the RISCUS randomized control trial as well. And the main thing to point out for spinal cord injury research is that the number of patients is actually not the most important factor. It's actually the granularity of the data, because as we know, time is spine, and it's very important that we have data from their acute presentation. A lot of the databases include ASIA exams of patients after they've had their treatment or after they're already in rehab, and that cannot really be used in at least the settings that a lot of us are involved with here, and that's the setting that a lot of the decisions are made. So we're very lucky that these data sets have information on acute presentation. So now we've talked about the data that we have available, and let's kind of talk about some of the predictors. And predicts is a very broad category. It includes anything from the injury to the type of treatment that patients are getting, and now more recently genetic markers and serological markers. And in medical school, we're all taught that, when a patient comes in, you do a history, it starts with an identification, social history, and then you make an assessment and plan. But as I kind of showed in our systematic review, the majority of the predictors are from the ASIA exam. So that's kind of one component of this history that we take. And it's important for us to consider everything, and we already are doing that as clinicians. When patients come in, we take everything into account when we're making our plan, but the models that are out there in the literature are not doing that. So that's something that, for the most part, some of them are, but definitely we need to kind of change that. And as outlined before, in terms of predictors, we need to kind of focus also more on treatment. And as Dr. Badiwala has shown, we're seeing more and more evidence how the impact of treatment such as early surgery on patient outcomes. So that's also important to factor in. So now let's talk about some of the specific model techniques. And we need to kind of think outside the box from logistic regression models. As we've seen this graph before, this traumatic spinal cord injury is not a singular disease. And I can challenge anyone to try to come up with a model looking at this kind of data. So you really have to break things out. You really have to kind of use novel approaches, and the kind of historic traditional statistics is not, it has limitations, especially when you use it in this sort of database. So some of the models that have been discussed earlier today, I kind of bring out some new other models that we've used. This includes this kind of multi-state modeling, which assumes patients are in different states at a given time. This is a survival-like analysis, and the advantage of this when it comes to spinal cord injury is that it allows us to factor in time. We know that time is a very important factor in any sort of neurological recovery or neurological disease, and it's important that we look at the time of presentation and time of the physical exam in respect to the injury when you're doing our models. And when we did this model, we found that it confirmed our theory that time is a very significant factor. We see that the more as a patient is in a specific ASIA state, the less likely they are to transition to the next ASIA grade. And this starts from the very beginning, in the first minutes actually from presentation. We see that there's the variability we have in the transitions is very high on initial presentation, and this kind of can last up to weeks to months. And we've also found that improvement is very region dependent. So in a cervical ASIA AA patient is not the same as a thoracic ASIA patient. These patients can simply not be compared in the same trial. And this kind of leads ways to kind of the novel machine learning models, that some of which Carlo discussed, and I'll kind of go over some of them later on in the talk as well. So the last thing we've got to talk about in a prediction model is the outcome measure that we're using. So the current outcome measure just mainly focuses on the total motor scores. The majority of the papers, as we saw in our systematic review, are looking at this. And there's a significant limitation when looking at ASIA motor scores. And this is coming from the fact that these are ordinal measures. So what that means is that they're taking a difference between the total motor score at one point and comparing to the other. But a 10 motor difference that doesn't necessarily correlate with functional outcomes. And the reason for that is that the distance from injury matters. A recovery, for example, below the level of injury compared to at the level of injury has different functional implications. And the specific myotomes also have relevance to function as well. For example, if you gain hand function, that's much different than if you gain some like sensation. And to kind of illustrate this point better, we have these two patients. Both of us have the same presentation as an ASIA injury as C8, but we see in follow-up, both of them had a gain of 4 points. And in the clinical trial, these patients would be viewed as the exact same recovery. But as you can see, patient 1 had some recovery above the level of their injury versus patient 2 is now gained motor function in their hands. And that corresponds to being able to use a wheelchair, for example. So you cannot say that these two patients are the same in terms of their outcome. But a lot of the prediction models, and more importantly, a lot of the clinical trials are out there, equate these patients to be the same. So that's what needs to happen. So we thought that, when looking at this, we really need to focus on ASIA A patients, because these are the patients that I think the motor level change has the biggest functional impact on. And we started with a very basic analysis, and that actually showed the best results. So we just kind of categorized patients into having significant gain, characterized by more than 2 muscle groups below the level of injury, versus not having significant gain. And we found that early surgery, for example, has an impact on levels gained in ASIA A patients, and this was statistically significant, and this held on the multivariate results. And this is an important finding, as one of the first times we've shown that ASIA A patients actually do respond to some of the treatments that we have, specifically early surgery. So now let's talk about, now they've gone over kind of the steps involved in clinical prediction models. I'm going to talk about the applications to trials, and this is kind of the main focus of my work for future trials. We really need to break down patients into homogeneous groups. And we need to identify better outcome measures that are sensitive to functional recovery. Spinal cord injury trials are already very difficult to conduct, and this is because they require multiple centers, and they also require the resources to be available immediately. And it's hard to kind of recruit the numbers that's required to show changes in some of these ordinal models that we have in such a heterogeneous population. So I think it's very important to kind of think outside the box, look at new prediction models that can be incorporated into the clinical trials and see changes in trajectories of patients versus just changes in ASIA grade. And for example, we can, break down, randomize, when you're randomizing patients, we can block randomize them based on the trajectory that they have instead of just block randomizing them into ASIA grades and looking at the, what the treatment, if the treatment changes the patient's trajectory. So again, the take-home message is here that spinal cord injury there's changing demographics, and this poses challenges in terms of determining prognostication. And current predictive models or historic models are limited, and there's a need for new kind of machine learning or advanced trajectory-based modeling, and you can do that with big data. And also, there's a need to kind of incorporate these into new clinical trials that are coming. Thank you very much.
Michael?
I'll comment with the disclaimer that obviously I have a clear-cut bias here, but nicely presented, Ali. So I think we're kind of at an inflection point with the way we need to think about doing clinical trials and clinical studies in our spine patients in general, in particular in spinal cord injury. But just a couple of reflections. So one is, has been this statement that you can't predict the outcomes based on the acute data, and that's because we get the Asia exams wrong. In fact, it's completely incorrect. We can predict with a high degree of accuracy the outcomes at a year based on trajectories. The challenge is that you can't just rely on the Asia exam alone. You need to use the other clinical variables, and that we need to stop trying to lump patients into these unrealistically large bins, and to think about individualized kind of trajectory modeling and kind of thinking a little bit around that. And then the other point, I think, just to kind of reflect on Carlos' comment, is just we never assess a patient when they come in and say, oh, we're going to make every decision based on your MGOA, or we're going to make every decision based on the Asia. And yet, when we design clinical trials, we still rely, on this naive concept of the one kind of primary outcome assessment. And I think probably, rethinking in terms of kind of multidimensional outcomes is going to be important.
Thanks, Dr. Fillings. Yeah, no, I agree. I think part of there's been a criticism on the Asia grade because people say that very early on the Asia grade is a moving target, but that's not the problem with the Asia grade of the physical exam. That's just how the patients are. In the beginning, they're just very undifferentiated. And I think, as Dr. Fillings mentioned, if you incorporate the time into the modeling, you see that it is a stable trajectory. It's just in the beginning, the patients are changing drastically, and that's the majority of the change they're having. So the challenge is with kind of the research and the modeling to kind of try to model that acute changes right off the bat, and we need the granular data, and we need some of the models that I discussed to do so.
It's a good point. I think the composite of our patients and demographics are changing over time as well, and I think a composite assessment and that are objective that takes a variety of factors in terms of the future trials, I think will be important. I guess you've had the opportunity to look at a variety of data sets, and these sort of span several decades. Our patients are living better in the sense of surviving some of these horrific accidents that they wouldn't have survived decades ago, and some of our patients are polytraumatized. You're not going to get an ASIA score on them in an expeditious sort of manner and things. And so I guess with the data sets that you've had, have you had any sense in terms of teasing out some of those changes in the systems? We've got more streamlined pathways to get them to level 1 centers more expeditiously, and expedited sort of MRI protocols and things like that that we really didn't have several decades ago.
Yeah, no, that's a very good point. So that's one of the main challenges with any of these harmonized data sets, that there's a big variation in the different data set they use. And I didn't go over this in my talk, but whenever you are combining these data sets, you really actually have to break them down to their initial components. You can't For example, if you're comparing the NASCUS-2 trial to the RISCUS trial, you can't just go based on their ASIA exam that they reported. You actually have to break it down to the individual myotomes and recalculate things completely, because the way they actually were calculating ASIA score even back then is a bit different than where we're doing it now. So that's the first thing. The second thing is that we are seeing that there are differences in the outcomes compared to some of the older data sets with the new ones. And whenever we are doing our modeling, we have to kind of somehow, there are mathematical corrections that you have to do. And the simplest way of explaining that is you try to essentially treat them as like a meta-analysis. So each one has one outcome measure, and you kind of have to provide a correction to that database to kind of match them.
Okay, terrific. Thank you.
Thanks.
Okay, our last invited research talk is Dr. Selina Nahani, and she's a graduate of the Orthopedic Residency Training Program, and so a fellow colleague now, and will be completing her fellowship at the Toronto Western Hospital. She has already advanced a degree in scientific research and is basically worked under the mentorship of Dr. Ramprasad and looking at a variety of important health outcome variables for our patient populations. She'll be speaking on the long-term patient-reported outcomes following perioperative adverse events in osteoarthritic orthopedic surgeries. Thank you, Selina.
Hello. So I realize that there's a number of neurosurgeons in the audience, so perhaps temper your expectations. I'm a graduate of the orthopedic program here at U of T, and I did a couple of things with Dr. Ramprasad through the years. This is one of them. So we looked at long-term PROS, patient-reported outcomes after adverse events in orthopedic surgeries centered around treatment of osteoarthritic conditions. So obviously, adverse events are a challenge. They're a challenge for the clinician, they're a challenge for the patient, and we've already established that they're associated with extended lengths of stay, increased costs, but there's sort of limited data on how these affect long-term outcomes. So we sought to examine the impact of these perioperative adverse events on these PROS, and our secondary objective was validation of the OrthoSaves capture system. So SAVES V2 was alluded to by my colleague Armand earlier today with regards to the spine element. OrthoSaves is a broadened version of that. One of its most powerful elements is that it's prospectively collected, and it can be collected by all members of the care team. So we have a much better capture rate for these adverse events. So there's a lot of studies that have shown adverse events rates in the neighborhood of 2 to 5%. These certainly reflect what are likely major adverse events, but they don't really reflect what are more minor events. And so what we've defined that as here, we have a 6-grade system, is grade 1 or 2 are minor, and those would be things that didn't really require significant invasive treatment. Like, for example, if your patient has 2 hours of urinary retention that resolves spontaneously, that would be a grade 1. If they have ongoing urinary retention overnight and they have to stay overnight, that would be a grade 2. And then, you graduate to the more complex interventions. Do they need to go to the ICU? Do they need to go back to the OR? Does this affect them for less than 6 months, more than 6 months, or indefinitely? And so that's the increased severity scale until you get to 6, which is death. So we use the LEAP-OA data set. This is a longitudinal evaluation in the arthritis program. So it was prospectively with prospective collection, but our last patient was recruited in 2019. It was collected over about a 5-year period. And we continued to collect data till 1 year post-op. And these were OA patients selected for elective orthopedic surgery. So these would be things like unilateral hip and knee replacements and lumbar spine surgery. We started off with about 1,700 patients, and we excluded younger patients, patients that needed revision procedures, trauma patients, and inflammatory arthritic patients. And basically, we have a few patient-reported outcomes. We have a combined from the hip and knee as well as spine. So there was the SF6D, SF12, that was the MCS or the PCS. Spine, we collected ODI specifically, and for hip and knee specifically, WOMAC pain and function. So our results were in keeping with previous findings. So the age of our patients was pretty consistent in the mid-60s. Those weren't significantly different. Cost was significantly different for no adverse events versus any adverse events, or minor versus major. Same thing for length of stay, or analogous for length of stay. So longer length of stay for any adverse event and even higher for a major adverse event. What's different here is that any adverse event category rate is about 38%, and this is dramatically higher than what's been previously reported. But if you look at our major AE, it's about 2.7, which is right on line. So it really speaks to the fact that as a whole, generally providers are underreporting their minor adverse events. So we're able to much more successfully capture those with this system. So here are some of our results. Combined spine, hip, and knee, SF6D and the 12. We have here significantly different outcomes for major adverse events. And you can notice the two green lines, those are no AEs versus minor AEs. They are not significantly different. But the major AEs are significantly different at the 3 and 12 month marks for the SF6D and the SF12 PCS. The MCS scores are not significantly different, but you can see that there's a trend that stratifies them. For hip and knees, the differential was more dramatic, so we can see that they're significant at all time points, and that's for major AEs versus minor or no AEs, and that's the same for both of the WOMAC scores. We adjusted these scores again for their baselines and came up with basically the same results. So the significance remained at the same 3 and 12 month time points, and the MCS similarly remained non-significant. Again, how we saw that again for the WOMAC score. So when these are adjusted for baseline, the effect persists. And what we unfortunately weren't able to capture is the difference in the ODI scores. This was likely due to a sampling issue. So unadjusted, you can see that there's a trend where likely we've got more disability with the major AEs. This is not, this doesn't persist when it is adjusted. However, if we compare our results to published work by Ailing a couple of years ago, we can see that our trends for the PCS and the MCS, the SF12, excuse me, are very analogous, and we have sort of similar-ish downtrending results, but what we can probably take from this is this other data set, the CSORN data set, was a few thousand patients, and our spine data was about 100 in our data set, so that's likely where that came from. So some of our take-home messages here are that there are not significant differences between the no adverse events and the minor adverse events categories. So this is in keeping with our grading system, so we can confidently say that grades 1 and 2 are in fact minor, and we can report and treat them as such. We do see significant differences when we start to look at major adverse events, and those are persisting at the 3 and 12 month mark. Those are particularly pronounced in our hip and knee patients as per our WOMAC scores. And all these differences are maintained after adjusting for our baseline scores. So major adverse events after routine primary orthopedic surgeries for osteoarthritis have a lasting impact on patient-reported outcomes at 1 year after surgery. So this gives us an idea of how we can counsel patients if they experience one of these sentinel issues. It can also give us prognostic information. And we have used the OrthoSaves system in our experiences here to have criterion validation of our OrthoSaves, and this is in correlation with the SAVES v2 that's been used extensively and been shown to be validated. Our long-term outcomes correlate with the operational definitions that are used to capture the events perioperatively. Thank you.
Carlo.
Great job. Did you look at any prognostic factors that can predict some of these adverse outcomes?
Yeah, well, I mean, we looked at sort of we did like break it down into the nuts and bolts. It's not, it ends up being things that have been predicted before, but it's interesting that that have been mentioned before, such as anemia levels and check my notes, sorry. But one thing that actually was really interesting is that some of the comorbidities that we looked at actually didn't really correlate with that. Things specifically like diabetes actually didn't correlate with that. But things like length of surgery were very tightly correlated with those. Yeah.
So I guess with this knowledge, and it's great, I commend Dr. Rambasan and team for the really the diligence in terms of prospectively collecting this and the accuracy of it and the data analytics relating to it. How do you take this back to the patient and their families, right? And so obviously you've got literature that may be a higher rate of adverse events than what may be reported historically. And minor to patient A may not be minor to patient B. And so I guess how would you take this in terms of counseling of what they might expect for their upcoming surgery and
Yeah, absolutely. I think that it gives us more information and a better, more standardized way of interpreting that information. So if someone comes in, say, for example, with, like I said before, urinary retention that keeps them in the hospital unexpectedly overnight, you can give them the assurance that that, in fact, won't impact them long-term, and we have some data to back that up. If they have more serious adverse events, like with an ICU admission, it's a bit intuitive, but we can say more definitively that their outcome horizon may be different than what it was predicted to be before. And I think expectation setting is a really valuable thing for patients, like in terms of how satisfied they'll be in the long term if you're able to be realistic about that.
And I guess with your major adverse events, there may be those that are, you can't really, it's not as preventable as others. And so is there any insights in those that
Yeah, I mean, that's kind of the million.
Or QI efforts get
Yeah, it's kind of the $1 million question. Like, how do you make sure that people don't lose enough blood? How do you make sure that that the surgery is short enough? So, that speaks to general quality of improvement in the OR. But of course, there's a lot of exceptions to that. For some of the complex surgeries that happen even at this institution, a lot of those things are unavoidable, right? So if you have a complex tumor surgery, hopefully your blood loss is going to be manageable, but it kind of is what it is at the end of the day. So when we focus on routine surgeries, I think the focus is always on checklists and pathways to minimize those events. So if the key to minimizing those events would be consistency and developing, a rhythm with the rest of your team, so that if something doesn't go as expected, people will notice, and then you can keep things more on track.
Terrific. No other questions? Thank you.
Thank you.
Okay, so the next session is going to be oral presentations based on our abstract submissions. And I just want to acknowledge again the faculty judges are from around the city that have helped in the selection of these presentations. And so the first presentation will be given by Leanna Abraham, supervised by Dr. Marguerite Akins, and she'll be presenting on assessing sarcopenia and treatment effects in a rat model of mixed osteoblastic osteolytic bone metastasis with imaging markers. Thank you.
Hi, everyone. I'll be telling you about my project on assessing sarcopenia and treatment effects in a rat model of mixed bone metastasis with imaging biomarkers. So as we know, prostate cancer is the most common cancer in men, and it's estimated that about 1 in 8 Canadian men will experience this in their lifetime. And it's particularly prone to metastasis, with the skeleton being one of the most commonly affected areas, seen in 84% of metastatic cases. So these bone metastases can cause lesions, which we can see in a CT scan like we have over here. These abdominal CTs of the lower vertebrae are used to diagnose and monitor the presence of these prostate cancer metastases. So in a normal, healthy bone, we have constant remodeling going on by our osteoclasts and osteoblasts. But in many diseases like cancer, when these tumor cells enter the bone, they can alter the regulation of these processes by these cells. So some types of cancers can interact with the osteoclasts to form osteolytic lesions, and others can interact with the osteoblasts to form osteoblastic lesions. And in either of these cases, we end up with a weaker, lower quality bone. Some cancers can create a mixed metastasis where we see both of these types of lesions, and this can happen in the case of prostate cancer. So as I mentioned, we can see the lesions in a CT. So this is a rat vertebrae. In panel A, we can see this is a healthy vertebrae. And in panel B, this is a tumor-bearing rat vertebrae where we can see this mixed metastasis. So in the top figure, we can see an osteolytic lesion, and in the bottom, we can see an osteoblastic lesion. Some standard treatments that are given for prostate cancer patients with bone metastasis include docetaxel. This is a chemotherapy which works by interfering with microtubule dynamics. And they are also typically given zoledronic acid, which is a bisphosphonate used to help reduce a patient's risk of fracture. So these lesions in the bone can cause symptoms of osteopenia, and growing evidence suggests that there's a significant link between this osteopenia and sarcopenia, which is common for prostate cancer patients and is currently not assessed in the clinic. So this is together known as osteosarcopenia, and it can significantly increase a patient's risk of falls and fractures. It can limit their mobility and significantly worsen their quality of life. So one of the muscles that are included in these serial CT scans is the psoas muscle that we can see here in the orange. And the psoas muscle is an important core muscle. It's involved in sitting, standing, walking, so we need it for everyday function. And it's been known to be used as indicators of overall musculoskeletal health, and it can be predictive of sarcopenia. So knowing this, we can leverage these serial CT scans where the psoas is visible to use parameters that we can get from the CT, like the volume and attenuation of the muscle, to assess sarcopenia. This brings me to the aim of my project, which is to determine imaging-based biomarkers to be used for the detection of early changes to the psoas muscle, secondary to prostate cancer and its treatment. To study this, our lab has developed a rat tumor model of bone metastasis. So we use immunocompromised male rats at about 5 to 6 weeks old. We need them to be immunocompromised so that the cells that we inject them with can be maintained and grow within the rat's body. And we use ACE1 canine prostate cancer cells that we inject them with to form these mixed bone metastasis. The cells are luciferase transfected, so we can see the development of the tumors within the rat's body. To form these metastases, we use an intracardiac cell injection. So we culture our ACE1 canine prostate cancer cells and inject them into the left ventricle of our nude male rats. And we've seen that this will lead to the development of spinal metastases after these cells circulate within the rat's body. This is an overview of our experimental timeline. Everything is in reference to the tumor cell injection on day 0. We also have a systemic treatment with either docetaxel or zoledronic acid on day 10 post-tumor cell injection. We also do serial CT and micro-MR imaging at different time points before and after tumor cell injection to assess the psoas muscle and the vertebrae. We have grip strength tests that we do at different time points to assess muscle function, as well as in vivo bioluminescence imaging to monitor the development of the tumors. So unlike humans where muscle distinctions are visible on a CT, this is not the case with our rats. So we have to use a micro MR with a gadolinium contrast so that we can better see the psoas muscle highlighted in green here. We can co-register our CTs and MRI images together so that we can see the bone and muscle together. And with this co-registered image, we can manually segment the psoas muscle and the vertebrae so that we can understand parameters like the muscle attenuation and volume from this. After the rats are sacrificed on day 21, we excise the psoas muscle and the vertebrae from T5 to L6. We can use these to do histological stains, and we can also use the vertebrae to scan in a high-resolution ex vivo micro-CT to use for stereological analysis. So we can confirm the presence of the metastasis in the vertebrae of our rats with bioluminescence imaging, as we can see on the screen. We can also use our ex vivo CT images to look for lesions within the spine, and we can also use histology of the vertebrae to stain the tumor cells. So when we look at the changes that we see in the rats with our changes in normalized psoas muscle volume from 1 day before tumor cell injection to 20 days after, we see that there are treatment-related effects where our docetaxel-treated animals within the healthy group have a significantly lower change in normalized psoas muscle volume compared to our untreated group. This can also help to explain what we see from our grip test results. So from the changes in grip strength from before treatment to after treatment, we can see that the docetaxel-treated animals have a significantly lower change in grip strength compared to our zoledronic acid and untreated groups within the ACE1 injected group. This can occur because a side effect of docetaxel is joint pain and peripheral neuropathy, which could also be contributing to this. When we look at the weight changes that we see in our rats during this time period, we can see that within a week after docetaxel administration, our rats' weight gain remains stagnant, which helps match what we see in the time frame where we see this change in grip strength. When we look at the changes in attenuation from day -1 to 20 during the experiment, we can see that the ACE1 injected rats have a significantly greater negative change in psoas muscle attenuation compared to our untreated animals within the docetaxel treated group. Since muscle attenuation and fat content are related, this suggests that our ACE1 injected animals have a higher fatty infiltration compared to our uninjected rats in this group. We also see treatment-related differences where our docetaxel-treated animals have a significantly lesser negative decrease in muscle attenuation compared to our zoledronic acid-treated animals, suggesting that the docetaxel-treated animals have a lesser fatty infiltration compared to the docetaxel-treated animals. We can further investigate this relationship between the attenuation and fatty infiltration using oil red O histology stains of the psoas muscle. So as we can see in the figure here, the red shows where there is fat in the muscle, and we can use a positive pixel analysis on this to quantify the amount of fat content in these slides. So we can see a treatment-related effect where our docetaxel-treated animals have a significantly lower fat content compared to our untreated groups and our healthy zoledronic acid treated group, which helps to match what we see with our attenuation changes. So in summary, we can see that psoas muscle attenuation and volume changes are measurable in this preclinical model of mixed bone metastasis, and we can see treatment-related differences as well as differences related to tumor presence. These imaging biomarkers can potentially be used to evaluate disease progression in prostate cancer patients and potentially be used to lead to the earlier intervention of osteosarcopenia. So I'd like to thank my supervisor, my committee members, and the members of the OBL lab for their help and support during this project, and thank you for listening.
questions. It's great work. I guess the psoas muscle, I mean, what about changes in other muscles, and are you able to sort of potentially do the same approach, looking at the sort of more dorsal paraspinal musculature versus the psoas? Or?
So for our rat model, the paraspinal muscles are not as clear, and when we use the MRI, depending on which MRI we're using, we can kind of make sure that we're only looking at the psoas muscle, but we also have the imaging from the paraspinal muscles, and that has also been shown to be predictors of sarcopenia. So the other side of our project that Dr. Hardesty was mentioning, where we're looking at the retrospective analysis from the patients, they're also looking into not just assessing the psoas, but kind of also looking at the paraspinal muscles.
And I guess the next steps in this work for you? Yeah.
Next steps are continuing to kind of increase the number of rats in our different groups. And we also have blood serum collected from our rats at all our different time points. So we're looking into doing ELISAs at these different samples from the different time points to see if we can find markers that are related to the changes in muscle and bone over time.
Hi, Leanna. So it's great to hear you present the work. It's terrific work. I'm just wondering, when you have the lesser fatty infiltration in the docetaxel-treated animals, is that a good thing in this animal model, or is that a reflection that they're not growing, that they have that loss of weight gain?
This is probably due to their weight changes. This is something that's seen with like chemotherapy-related effects. We also see like loss of muscle mass related to the chemotherapy treatment, but this is most likely to their loss of weight or stagnation in weight at this time.
Okay, terrific. Thanks so much. Okay, so in the clinical realm, we have an eye for the best abstracts, and the first presentation will be given by Dr. Arya Zohar, who's completing a fellowship at the Toronto Western Hospital, and he will be presenting on saving spinal cord function by using intraoperative monitoring and rapid response during spinal deformity surgery.
Hello. Good afternoon, everyone. My name is Ariel, and in the following minutes, I'm going to discuss work that we've been doing here in the Western and all around the world as part of the SDIM project. And our part of the study was to find out, like, how good is IONM in preventing neurological deficits during deformity surgeries. Yeah. So take a look on your right. Everyone who does deformity surgery or spine surgery in general knows what he is looking at. This is an output of MEP during the surgery. You do a certain maneuver, place a screw or some sort of other implant, and you see, the technician reports to you that he sees a decrease in signal in some muscle groups. So usually, as an instinct, we all know what we should do. We should reverse the last thing that we did during the operation. And this is an actual good decision to make during an operation. And in general, IONM is considered the standard of care during deformity surgeries. But the problem is that the occurrence of new post-op neurological deficits, as reported, is varying in rates and varying in treatment during the operations. Sorry. Now, this is a makeshift checklist that I found on the internet just a few days ago. It refers to the surgeon, the technicians, and anesthesiologists with regard to what we should do during the operation. It is very short. It is very effective, probably, but it's based only on an expert opinion of a few surgeons who works in that specific institution. This is an attempt that was done 2 years ago by the SRS to formalize something that is more standardized. And this is their checklist for what surgeons should do during while receiving an IONM alert. It refers to the different stages of the operation. For example, here we see over the first stage, during the stage of the decompression, what a surgeon should do. And it progresses to what should be done later on in the stage, what is referred to as 2B, for example, when doing some kind of osteotomy. And of course, the recommendations are different for a case of kyphoscoliosis and lordoscoliosis. It is still expert opinion. It is still based on expert opinion and not on a large body of data, first. Second, it doesn't refer to any alert or pattern of alert specifically, whether it is MEP associated or SSCP. So this work, as the name suggests, is to provide surgeons with tools and knowledge they need to optimal patient safety. 20 international centers have participated in this study from all around the world, and this study is a prospective, standardized, observational multi-center study. The inclusion criteria to be considered to this study is anyone, any patient who is going through a major deformity correction between the ages of 10 and 80 who is neurologically intact, and it should have a significant cone angle and having some kind of significant osteotomy about to be done on his spine. EMG, SSCP, MEPs are mandatory during the study. These are our endpoints eventually. And IONM change is defined as loss of amplitude of 15% or more in SSCPs or MEPs, or sustained EMG activity of more than 10 seconds. Detailed neurological examination based on angioedema is taken at baseline, post-op, and before discharge or 30 days after the operation, what comes first. This is an example of a paper of the sheet or the alert form that was filled up by the technicians during the operation. It shows the technicians should fill up rather the alert was EMG related, SSCP or MEP, and the amount of signal loss, and the group of muscles that were affected. Another part that you should fill was rather it was decided as a surgical cause or an anesthesia cause for the loss of signal. And what proceeded if it was a surgical cause, so rather it was before or because of the placement of the implant, rather because we had an osteotomy during this phase of the operation, and what was the response to the alert. And of course, if a wake-up test was done, and time to recovery of the signal, the amount of recovery, and if at all. Our results of the study show that out of about 350 patients all around the world who had major deformity surgery, about 17% of them, which is 57 patients, had no alerts, had alerts, while all the others, about 83%, had no alerts. There were no significant differences in terms of demographic or surgical values. However, in terms of significant differences between two groups, we found difference in terms of Cobe angle and deformity angular ratio. As higher these variables are, the chances of having an IONM alert is higher, as known from the literature. MEP was by far the most common type of alert during these operations, with 96% of the alerts are MEP associated, and SSCP came second with only 15% of the cases. The alert preceding the alert were surgical in most of the cases, about 80% of them, with 40% of them were related to osteotomy or correction or rod placement, And instrumentation placement, which is basically screw placement, came out third at about 17%. To the question of the study, rapid corrective action reverse the alert in about 80% and shows us some recovery in the MEP changes. And in patients with IONM alert, in total, about a quarter of them at the end of the surgery, if they had an alert, will have eventually some kind of deficits. 20% of them will be motor dysfunction, with about 6% being sensory. If a patient had between 50 and 75% of signal loss, the probability of him having some kind of deficits is about 15%. As it goes higher, to the second group between 75 and 100, his chances of having any kind of deficit is about 1 to 4, about 24%. And if he lost all of his signal during the operation, even if it came back, he has a chance of about 50% of having some kind of deficit at the end of the surgery. In total, about 8% of our population develop new post-op neurological deficits, with about half of them having no IONM alert at all during the operation. Our conclusion that the MEP type is the most sensitive of all modalities in terms of detecting some changes in the spinal cord, and 8% of new post-op patients will have some kind of neurological deficit in total, and half of them have no alert during the operation. Our conclusions are that alerts should be considered as a critical event during the operation, and they can be reversed and should be reversed with however maneuver possible. And in patients with alerts, expect that about a quarter of them at the end of the surgery will have some kind of deficits. And 4% of false negative rate shows us that there are limitations to this method and it should be optimized. Our next objectives in this work and in other works in the future is to model the corrective processes and the insulting process. We assume that some of the maneuvers we perform during the surgery put our patients in a higher risk in relation to others. And that the SSCP, because of the very low sensitivity threshold, we consider it to be altered. We might need more channels during the operations in order to make it more effective. After all of the study will be completed, of course, we'll present our final results, and hopefully our protocols and thresholds will be adjusted in a manner that will allow better safety for our patients. Thank you.
Important paper, and I think it's great to have the data out there. So it'll certainly add to the literature in terms of the accuracy and kind of the validity of the monitoring, and also importantly in terms of kind of what the outcomes are. I think that kind of in addition to kind of having maybe an objective assessment of the intraoperative neuromonitoring changes, I think what I'm hoping we'll see will be an adoption of the 5-stage care pathway that we've proposed, right, around the identification and prevention, and then kind of the team discussions, then kind of what to do related to that. And I could see that then having kind of a sheet related to the intraoperative neuromonitoring changes, and then potentially interpretations and suggestions. I think that'd be really good. Congratulations on that.
Thank you.
Dr. Hugh?
Very nice work. You looked at the extent of the loss of motors and how likely that was to predict a deficit after surgery. Did you look at the time to return? Because in my experience, I've found that if the more quickly the signals return, the more likely it is you won't have a deficit. And I didn't see that data in yours. Did you have?
We looked at that as well. I don't quite remember the numbers, but there is an association between the two, between the time to return of the signal, if at all, and the amount of return.
Was there a threshold at which you'd want the signals to have come back to expect a return, or?
If I remember correctly, is about half of the loss was our threshold, but I don't quite remember this one.
Okay, thank you.
Other questions? If not, thank you very much. Excellent. Okay, and the last talk in this session will be Dr. Hussein Shakil, who's a neurosurgery resident and surgeon scientist trainee at the University of Toronto. He's working on his PhD through IHPME, and he'll be speaking to us on days alive and at home after treatment of spinal metastasis, measurement of patient-centered outcome using population health data.
Okay, thank you, Dr. Yi, and I'd like to congratulate you and Dr. Failings for another wonderful SpineFest. It's great to see all the terrific research being done around the city. And welcome to Dr. Yu as our visiting professor. And my name is Hussein. I'm a fourth-year neurosurgery resident. And I'm supervised by Dr. Wilson, who unfortunately is not here today, but he's a spine surgeon at St. Mike's. And we're looking at measuring this patient-centered outcome known as days live at home for patients treated with spine mets. So as many of you in the audience know, patients with spine mets suffer from significant disability as well as reduced quality of life due to sort of microinstability as well as pathologic compression related to tumors in the spine. And the spine is actually the most common site of bony metastases for both solid and hematologic cancers. As much as 30% of patients with cancer can get bony metastases, and then the most common site is the spine. And previous estimates have been that direct healthcare cost is about $500,000 US per patient for the first 60 days of treatment. So this is really quite an impactful disease on the healthcare system. And the primary modes of treatment today are surgery and radiation. And so a lot of the motivation for this project was born out from experience I had in junior residency. We had about three patients on our service that needed treatment for spine mets. One of them did quite well, was able to get home and discharged to undergo subsequent forms of treatment. The other one, unfortunately, suffered from intraoperative sort of cardiac arrest, and then subsequently was in ICU for a prolonged stay and didn't quite make it home. And then the last one had an early mortality. So this kind of highlighted to me that there's a spectrum of outcomes that we see for patients with this disease. And unfortunately, some patients, they suffer from early mortality after treatment, whereas others are able to make it alive at home. So I kind of wanted to look more into how we can better assess these outcomes for these patients and better describe and manage expectations after surgery. So in the general surgical oncology literature, there is description of this outcome known as days alive and at home, where it's looking beyond just sort of mortality and survival, but also more at how much time patients spend at home after treatment. And so this has been sort of borne out from previous studies on critical care patients as well as sort of general surgery studies. And it's not yet been described within the spine mets population. And so some of the questions that we had starting out was, what is the optimal time window for measuring this outcome? And are there specific patient factors that we can look at for significant differences in days at home? So basically, we want to measure days alive at home after first treatment of spine metastases, and this is either surgery or radiation. So to this end, we conducted a retrospective observational cohort study, and we linked all cases done in Ontario, registered within the Ontario Cancer Registry, as well as Cancer Care Ontario. And this was between 2007 and 2019. And we looked at all adult patients over 18 years of age that were undergoing either surgery or radiation or the combination of the two for treatment of a spine mets. And we looked at days at home measured either within a 30-day window, 90-day window, 180-day, 1 year, or 2 years. So this is basically the acquisition of the cohort. We linked data from both OHIP and Cancer Care Ontario registries and looked at a look-back window within other population databases to find comorbidities as well as primary cancer types. And we measured our outcomes using a combination of data linkages from other institutional databases that allow us to measure the amount of time spent within either inpatient care, emergency medicine care, or rehabilitation. And so the way days live at home has been described in the past in terms of how it's measured is you can take a specific time window after treatment and then look at different institutional databases, for instance, CAI or the National Rehabilitation Registry, to look at how much time is spent within different sort of episodes of care. And you can subtract off that time from the overall survival that's registered within the registered person database and look at from there how much time is spent at home. So this is the flow diagram for the study for our patients. So we had about 36,000 patients with spine meds treated in Ontario that we were able to identify. And we importantly excluded off any patient who had a primary spinal tumor, a primary tumor of the actual spinal cord or the meninges, to look specifically at tumors that have spread from either solid or hematologic cancers. And these are the demographics that we looked at. So mean age was about 64 years, sort of similar balance between male and female, and sort of the common types of tumors that we typically see for spine mets were represented, so breast, GI, lung, myeloma, as well as prostate and urological. And one thing to note was that the majority of patients included in our study were from urban centers, so we didn't get good capture from rural settings, but we do think that a lot of these patients are sort of residing within these places. So this was the survival curve that we had for our cohort. Median survival was about 152 days. And then if we compare this to prior sort of institutional experiences, so one of the studies on the bottom is the experience from the New York group, MSK, and they had a pretty similar median survival, and another study from another Ontario-based study. So we were pretty confident that we were identifying a cohort that was representative of the experience that other people are having in different institutions. These are the main results in terms of the days spent at home for the different time windows. So what you can see is that within the first 30 days, the majority of patients, or at least 50% of patients, are spending the majority of time at home. It's very sort of upwardly tail-bound towards a ceiling effect of 30 days. And then as time goes on, there's more of a spread within the population. So you sort of identify seems to be sort of two subgroups, sort of patients who are a bit more able to get home and do well, and those who have early mortality and spend a lot of time in and out of the hospital. So these were the actual numbers. So at about 6 months, you can estimate that about 50% of patients will spend at least or at most 114 days in hospital. And then that's, if you look at the confidence intervals that were measured through Bootstrap, that this is significantly similar to, or not significantly different from the estimate at 1 year or 2 years. And this graph sort of shows us in graphical format. So there's a bit of an asymptotic relationship after about 6 months, where you kind of get a good estimate of long-term time at home from a population perspective. So then we want to look at patient factors associated with significant differences in terms of time at home. So some of the important findings here, we've heard a lot about frailty and age in terms of all the talks today, and as you can expect, this is an important factor for these patients. And one of the estimates that we have was for every 10 years longer than the mean age of the cohort, which is about 64 years, patients spend 45 fewer days at home. And in terms of cancer types, things like lung cancer, hepatobiliary cancer, and melanoma were associated with more than 3 months less at home compared to something like prostate cancer. And a lot of these results were re-demonstrated and robust to our analytic method. So as a sensitivity analysis, we also were able to re-demonstrate the results using a negative binomial regression. And one of the other things that we looked at was a predictive validity of 6 months for longer-term follow-ups. So what we found is that there's a strong correlation with days live at home at 6 months with measurement at 1 year. So this sort of says that, when you're assessing these patients sort of on a larger population level, that how they're behaving or the amount of time that they're spending in and out of hospital within the first 6 months is really representative of what you can expect sort of for the remainder of their time. And so in summary, the major strengths that I'm presenting here today are sort of a pragmatic, interpretable outcome. A lot of the times that the things that we look at within these papers are survival outcomes, and we report hazard ratios, which are not as interpretable for patients, but the exact amount of time estimated after treatment, I think, is something very valuable to know from a patient perspective, and I think will help with setting expectations after treatment. And we were able to employ a large sample size by taking advantage of population data here in Ontario. And we provide a novel reporting of this outcome for this patient population. So some of the limitations are largely borne out due to the study design. So this was a retrospective observational cohort study. So as such, we're subject to unmeasured confounding, especially in relation to some of the patient factors that we're looking at. And we're also selecting specifically for permanent residents in Ontario who are eligible for OHIP. So as you can imagine, patients who are new immigrants or for other socioeconomic reasons are not eligible for OHIP, we would not be able to generalize these results for them. And I think it's also important to note that I think we should look in the future at patient-reported outcomes to see if more time at home actually correlates with better reporting of health-related quality of life and these sorts of measures. So those would be something to look at in future studies. So in summary, more than 50% of patients spend less than 125 days at home after first treatment of a spinal met. Home time is significantly shorter for older, frail patients, and lung and hepatobiliary cancer seem to be the types of cancer with the shortest time at home. And we're presenting here real-world data, sort of not within a controlled setting, on patient-centered outcome that will help enable, hopefully, decision-making and manage expectations after treatment. So I'd like to thank the different collaborators for the study, and most of all, my supervisor, Dr. Wilson, for providing the opportunity to do this work, and the organizers of this session for providing the opportunity to speak here today. Thanks.
Yeah, it's important work, and there's been a shift in the way we assess and treat metastatic spine disease, but the data that you present around the median survival is still quite sobering. And I'm part of some study groups that have a vested interest and a focus on the management of spine metastases. But some of the data that sometimes emerges from selected surgical registries, I think sometimes present a bit of an unrealistic picture, let's just say, of survival. And I've seen some interpretations suggesting that there are these big shifts that have occurred in the survival of spine mets. And I think your data, I think, present, probably a more realistic, sobering expectation. That's, I guess, a comment. But the other comment is, as you're reflecting on it, I think it might be interesting just to have a look to see if the proportion of some of these patients that are outliers are shifting. Because my sense is that while maybe we haven't seen dramatic shifts overall in the median survival, that there might be a bump in some of the outliers, like, so for example, EGFR positive lung cancer as an example, right? It's not a huge population, but that there's a bump in that group. So it might be something worthwhile to look at.
Yeah, no, those are really great points, and I think identifying those people that are outliers would be particularly important, and I think future work for sort of prediction models and risk stratification. So yeah, very good comments.
Dr. Eakins?
A very interesting study. Is there anything known how the degree of metastasis were, if they had one level or several levels affected by the metastasis, and how did that influence the results?
Yeah, there's been a lot of other prognostic scales that have been published before, like Takahashi or Tomita, and those sort of look at the number of METs across the spine. And I think there's also been one called from the Spine Oncology Study Group called the SORG study. But the data that we present here, it doesn't have a lot of imaging stuff related to it, so we don't have the number of METs to the spine included. But I think it would be good to link it with some sort of other registry that has that to incorporate that. Because I do think it's an important factor, you know. A patient who's sort of riddled with mets around their body is pretty different than one who has maybe a solitary spinal met that you can kind of resect. So, yeah.
So thanks so much. I'm just wondering, what was the most surprising finding from this? Because a lot of it, they have terrible forms of cancer that are very aggressive. Not surprisingly, they're not at home. They're very frail. They're not at home. What's the most surprising, either positive or negative, that you found when you're looking at this very large cohort and interesting data set?
Yeah, it's a good question. I think like in the positive way, there were some kind of, to Dr. Failing's point, there were some patients who were surviving quite long. And I think those are maybe patients who have maybe a solitary kind of spinal lesion and you can sort of resect it quite well with surgery, and adjuvant therapy is allowing to keep their cancer quite at bay. So that was sort of reassuring that, you know, there are some patients, hopefully we can sort of work towards identifying those better and sort of be more encouraging and more optimistic. But I think, you know, there were a lot of sort of expected findings in the terms of frailty and older age. And I think nonetheless, sort of quantifying that with a number helps expectations and management nonetheless. So that's kind of my thoughts on that.
I have a question, Hussein. Congratulations for this important work. You use the ICES data, right? Does this data set allow you to subtract days? For example, this patient is readmitted in the hospital, for example, or that's my first question. The second is, how did you deal with patients who are baseline institutionalized and were not living at home, for example?
Yeah. Good question. So any sort of readmission or episode of care within an Ontario institution would be subtracted off from sort of the time of index treatment towards the last date of your follow-up. So that would be kind of captured. The only thing I would say is if there was, for instance, a patient who was referred in from the States and then they got readmitted somewhere in the States, maybe that wouldn't be properly captured because it would have to be occurring within Ontario. So that's for the first part. And then in terms of patients who are already institutionalized, so I did look at, there is a small percentage that at the time of diagnosis, they're already admitted to hospital. And I think all that happens is that if they remain institutionalized, their days alive at home would be 0 within the follow-up period. So it would sort of be reflected in the number.
Terrific work. Thank you. Excellent. You know, looking forward to the next phase of things when you sort of look at that quality of life when they're sort of days at home. You know, are they ambulatory? How pain-free are they, et cetera? So, very important work. Thank you. Okay, so Michael and I have the privilege now to segue over to the awards presentations, and I guess the first recognition is really to our distinguished guest. Thank you, Dr. Hugh. Let's ask you to come up.
So, Serena, thank you for your wonderful contributions to today. You're not quite off the hook. We've got the GTA spine rounds tonight, but we have a few little tokens of our appreciation. As I say, the check is in the mail. However, we have something for your desk. We have a coveted U of T spine program scarf, and then a little autographed book, which is a great cure for insomnia. Thank you so much.
Thank you so much. It's been an honor to be here. I really appreciate it.
We just get a picture. Let's get a picture straight. That works. Great.
Thank you.
This is gorgeous.
Okay. And then, right, yeah. So we've had a really a wonderful afternoon. Some excellent presentations from the trainees, and I really think that you know, as was indicated this morning by a number of the faculty in their remarks, really a big strength of our program of the trainees. So I'd like to call up each of our invited research trainees to get a certificate. So first, Dr. Carlo Pedro. And we have our photographer, Ian, here. Super. And then next, we have Dr. Ali Mogadamju. He's flying solo. Okay, so we'll give that to Ali later. Maybe if one of his colleagues could give that to him, and then Selena. Great.
It's after to move a little bit so that you're.
Thank you. Thank you.
Great. Okay. Then we had some fantastic abstract presentations, and really I just want to congratulate all of the trainees. Fantastic presentations. The elevator pitches were amazing. The judges had a tie between Hussein Shakil and Ariel Zohar for a first place clinical. So if we kindly ask Hussein to come up first. Come on. Good.
Very nice. Thank you.
And the co-first place winner for best clinical paper is Ariel Zohar. So Ariel. Very nice work, Ariel. Why don't you come in the middle? Very nice work.
Slide over a little bit.
Yeah, we'll just come.
Can you move a little bit to the left? Thank you.
Right. And then first place basic science is Leanna Abraham. Leanna here? Yeah, very nice. Very nice work, Leanna. Congratulations. Fantastic. And I wonder if I could ask Dr. Carrie Wine to come up. And Carrie and the judges, I saw them hard at work while we were feasting on lunch. They were hard at work, slaving away, assessing the best elevator pitch. And that would have been tough because there were some pretty amazing presentations. Carrie, over to you.
So thanks so much for everyone who took the time to do that. So it was a tough decision. We have a couple of honorable mentions, and then I'll go. So the two honorable mentions went to Youssef Al-Jaman, which is a prospective observational multi-center study assessing functional improvements after multi-level fusion for adult spinal deformity, the 5-year follow-up results, and also Sydney Brocky, an examination of the roles of CX3, CR1, and microglia in degenerative cervical myelopathy. So congratulations to those two. And then finally, for our winner, we have Jennifer Dermott, Socioeconomic Disparity Limits Opportunity for Conservative Management of Idiopathic Adolescent Scoliosis. So congratulations to everyone. Oh, is Jennifer here? Oh, I don't mind.
And the checks are in the mail also.
Sorry, I didn't see you in the corner.
Or I guess e-transfer is probably these days, right? Okay, amazing. There you go. Hand over to Albert to, I think we're ready to close out, right? Okay. So evaluations here. And are these QR codes in the program as well?
That's the brochure.
Perfect. Yeah, so if you take a few minutes just to take a picture, and we appreciate getting your feedback. The event is CME accredited, I think, right, as well, right? So the evaluations are important, and if you have suggestions, for future themes, speakers, and so on, that's always greatly appreciated as well. Although it'll be hard to top this year's speaker, who was amazing.
Yeah, and so I think, Michael and I would like to take this opportunity. It's every SpineFest is sort of memorable, but, I think this year is Michael and I sort of reflect on the last several years and really value and appreciate the support of the entire faculty, the community, our interprofessional team, and importantly, all our trainees. It was just great to see the depth and breadth and diversity of the types of projects that our students, trainees, clinical, as well as fundamental trainees are all involved with, and to see your successes and to hear about your journeys and your results. Certainly it's gone a long way, and obviously the main goal of all of this is to really enhance our efforts as we provide care for our patients, particularly increasingly sort of challenging times in terms of the sort of health system that we currently sort of reside in. But these type of efforts, I think, are critical. And, I think Michael and I are sort of privileged to be involved with sort of hopefully setting up a sort of solid foundation from which to continue to grow SpineFest. Special thanks to Dr. Hugh. It's really great hearing the importance really of the history of where we've sort of come from. And, I think as Dr. Towles and others have said, if you don't learn from history, you're sort of destined to repeat it. And, I think, there's a lot of rich history of spine surgery here and spine care and academia at the University of Toronto. I guess when we sort of first, thought of organizing this event, the first one was held actually in 2008 before the formalization of the program underneath the university department, and sort of coming up with the thought for the event, sort of SpineFest. The FEST actually refers to the Forum for Emerging Spinal Technologies, and that's sort of initially where the idea sort of came from. And lo and behold, 16, 17 years later, and it's still happening every year. And I hope it provides a good opportunity for everybody to connect. We've received a lot of tremendous support through the university as well as our industry partners. This evening we'll be celebrating the graduation of our clinical fellows, and we'll have some additional sort of entertainment, and our expert photographer will be also making some I think entertainment and some enjoyable music that I think we'll enjoy over dinner. So with that, we'll formally close the program, and thank you so much for staying throughout the day.
All right, enjoy the rest of the day, and some of you will see tonight.